And thank you, Representative Soloway, for the periodic wellness alert yesterday to encourage me to leave in a timely manner. That was much appreciated. And
I'm glad that you got home safely, Mr. Chairman. I was concerned.
that's why I texted you and let you know I was home safely.
I enjoyed the exchange on imminence versus imminence.
That's right. That's very important. They mean different things.
I think that only thee and me know the depth of the difference.
Do you know the difference between flammable and inflammable?
No.
There is no difference.
Both will burn,
Both will burn.
and we shouldn't address you as your eminence. Only
Well,
that snowstorms are imminent.
Eminence is one title above mine, so don't do that to me, please.
All right, we're all set to go when you are, Representative Pearson.
All right. Is the general public now available?
Yes, they have been available.
Public. Well, I have to read the script.
Please.
As chairman of the House Health, Human Services, and Elderly Affairs Committee, I find that due to the state of emergency declared by the governor and as a result of the COVID-19 pandemic, and in accordance with the governor's emergency order number 12 pursuant to Executive Order 2020-04, this public body is authorized to meet electronically. This is a committee meeting with hearings on bills and possibly executive sessions as well. Please note there is no physical location for the members of the public to observe and listen contemporaneously to this meeting. However, in accordance with the emergency order, I am confirming that all members of the committee and select legislative staff have the ability to communicate contemporaneously during this meeting through the Zoom electronic meeting platform. And the public has access to listen contemporaneously, and if necessary, participate in this meeting by the Zoom platform or by telephone. All necessary access information has been made available in the House calendar and through the electronic calendar on the General Court website. Notice for this meeting complies with the House rules and RSA 91-A. Anyone who has a problem accessing this meeting should call 271-3600 or email hcs@leg.state.nh.us. In the event the public as a whole is unable to access the meeting will be adjourned and rescheduled. Christina Dyer, committee researcher, will be the staff member assisting us. Please note that all votes are taken during this meeting shall be done by roll call vote. We will start the meeting by taking a roll call attendance. When each member states his or her presence, please also state whether there is anyone in the room with you during this meeting. This is required under the right to know law. Would the clerk please call the roll? And when your name is called, make sure please you are unmuted.
Good morning, Representative Marsh. We have him as absent, correct?
Yes, he will be coming in probably within an hour or so.
Okay, thank you. Representative McMahon.
Present.
Where are you? And anybody in the room?
Oh, pardon me, Mr. Chairman.
right.
I'm at my home office. I am alone, although my wife and son are in other parts of the house.
Representative Nelson.
Here in Brookfield, and my wife's in and out.
Representative Acton.
I am here in Fremont and I'm alone in the room, but both my wife and daughter are in the house.
Representative Gay.
I'm here in Salem in our office and my husband is in the house.
Representative Cushman.
I'm here in Ware and I'm alone in the room, but my family is in the house.
Representative Folsom, I'm here in my home and I have a good looking guy hanging out in the room next door. Representative Kelsey,
I'm here in my home in Bedford. I'm alone in the room, but my daughter and husband are in the house.
Representative King,
I am here in Milford and I'm alone in this part of the house, but my son is upstairs doing studies today.
Representative Kofalt,
I am here in my home office in Wilton, and there are other people in the house.
Representative Weber,
I am in Concord and I am accompanied only by a standard pool.
Representative McKay.
Representative McKay, hold the
McKay.
space bar down.
I can see him and I'm reading his lips. So I'm going to put him in as here. Representative Snow.
Yes, I'm here in Manchester in my apartment. My wife is also present in the apartment, but not right around.
Representative Knirk.
Yes, Jerry Knirk here. I am here in Freedom in my study. My wife is somewhere in the house now, but we'll be out tramping in the woods later.
Representative Soloway.
Good morning, all. I am alone in my home office in Lee, New Hampshire.
Representative Cannon.
Hi, I'm home alone in my home in Somersworth, New Hampshire.
Representative Nutter Upham, sorry.
I know it's
Sorry.
not calling me Butter Upham or. Thank you so much. Good morning. I'm in my home in Nashua. My husband is elsewhere in the house.
Okay, thank you. Representative Shapiro.
I am home in my office in Keene, alone.
Representative Woods.
Yes, I'm at home in Bow, in my study, alone. My wife is elsewhere in the house.
Representative Merchant.
Yeah, excuse me. I'm home in Claremont, and my wife is somewhere in the house.
And Representative Pearson.
I am home in my office in Hempstead, and my wife is working hard in the other room.
Thank you.
Before we begin the first hearing, I'm afraid I have to be the bearer of bad news, and this is from the world of science. Punxsutawney Phil saw his shadow today.
Yes.
No.
Yes.
You may have all of my snow, anyone who cheered. All right, I am looking for my gavel because that was a present. Oh, here it is. Okay.
And while you're doing that, I'm going to remind Representative Snow to mute his.
Thank you.
Got it.
Going to open the hearing on House Bill 617 relative to food safety training for child care centers, and the chair recognizes Representative Schmidt to present the bill.
I'm on the wrong day. Oh, that's Monday.
Jeff, you're not muted.
Yes, I'm sorry.
Am I there?
I do not see Representative Schmidt on my call-in list.
I have her here. She's ready.
Oh, okay. Thank you.
And I am online.
We can hear you, Representative Schmidt.
Excellent. Good morning. This is the most fun committee I've ever attended. You folks you're awesome. Thank you, Mr. Chairman, and honored members of this most hilarious committee. For the record, my name is Jan Schmidt, and I represent Nashua Ward 1. And I'm here to ask you to pass HB 617, a tiny, tiny little bill. Last year, a constituent asked me to help her with children and allergies to keep them safer. So between OLS and us, we wrote a huge bill, which would sweep all we wanted into one bill. The Education Committee loved it, but the testimony from school nurses told us that they already do all of this. So much is done in rules, and of course, that's an appropriate place for requirements like I've got listed on the sheet I sent you. So it went to interim study, and I heard this from one of the subcommittee members. It was pointed out that 200:44A covers everything in the bill except daycare. And that should go to Health and Human Services. There you go. So here we have HB 617. Any person employed by and serving food in a licensed child care center shall pass a food safety class meeting the standards of the Conference of Food Protection. Now, I have an allergy to peppers, and one bite of the seeds or the skin, and within hours, I've got this volcano brewing inside. But I know what I need to know to avoid this. With no nurse on site, children in daycare rely on those adults caring for them to ensure their safety. This small change would mean a big difference in the confidence we have in the folks who care for our smallest neighbors. So I ask you find HB 617 ought to pass, and I'll answer any questions I am capable of.
I see a hand from Representative Nutter Upham.
Good morning, Representative Schmidt.
Good morning, neighbor.
Hey, how are you? I was wondering, does it specify how many hours of training the server would need to have?
I need to do more research on the Conference for Food Protection, but it's simply a safety class.
Okay, that sounds good. We heard other things about hours of training for people who work with people who have Alzheimer's and, you know, whatever. And the hours of training was kind of the issue. So a class in training. Okay,
That's
thank
correct.
you very much. Thank
You
you
bet.
for answering my question.
Representative Weber.
Thank you, Mr. Chairman, but I had exactly the same question as Representative Nutter Upham, so I will lower my hand now.
Representative Acton.
Good morning, and thank you for taking my question, Representative Schmidt. I've done some work. Matter of fact, excuse me, I'm working with Representative McWilliams on a variety of reforms of child daycare centers. And one of the issues that we found in the study that we did, where we had over 60 people show up and testify, is that they're already required to have 18 CEUs a year of training. And this is a huge burden, especially on the smaller mom and pop style daycare centers that are out there. So I guess the question is, would this training be, would this fill the requirement of the CEUs? And how much does it cost the center to bring in a course like this? Because it certainly isn't free.
I don't know, but I think this is provided by the state. I think that you can take this class. I can do the research and find out for you.
Okay, we follow up.
Yes, follow up. Thank you.
Okay, yeah, we should probably talk about this because we have we're having another study this time. Rebecca and I are doing a lot of work on trying to get a hold of the regulations on child care centers. We're losing for every 4 that go under, only 1 opens, and it's been made even worse in the time of COVID. So I was wondering if we could perhaps maybe talk about this and try to fit it all together, because we have a piece of legislation that's trying to cut the amount of CEUs down to a more manageable level for these centers.
I think anytime we're talking about regulations and making changes in them, the best thing obviously to do is look at the whole picture. And if some are outdated, if some are duplicated, if some are missing, this is the perfect opportunity to make sure that the whole thing is made whole. That's an excellent idea. Thank you very much, Representative.
Okay,
Representative
thank
Schmidt,
you.
I'm going to call on myself because this is a follow-up to what we just heard. I believe you told me 200:41A covers everything except licensed child daycare centers. So the question would be, are they covered anywhere else in statute? And so therefore we are trying to fill a gap, or are they covered? We just heard 18 hours. Could you help me with that, please?
As far as I know, food safety for children with allergies is not covered anywhere.
Follow up to myself, had you considered then making this a requirement for everyone and not just licensed daycare centers?
A requirement for someone who doesn't go through a licensing procedure might be very difficult to follow up on.
Okay, thank you. Representative Woods.
Thank you, Mr. Chairman. Question about, and thank you for taking my question, Representative Schmidt. Who is this Conference for Food Protection? I asked that because I just ran across this as chair of the Workers' Comp Commission, and who could provide certain services. Turns out there was 436 credentialing agencies in the US, 136 of them in Las Vegas. We were able to change that to just the American Board of Medical Specialties to get have certain credentials. What is the status of this Conference for Food Protection, and how do they gain this prominence in our proposed legislation?
As far as my research has done, it's a nonprofit organization that's began about 30 years ago, and it's a formal process to follow food safety issues. If this is an appropriate place to make sure that the class is done, that's fine, as I had just said with Representative Acton, that if we could make sure that the allergies safety is covered under any current law for daycares, this would incredibly make a difference for some of the families I've spoken with.
Follow up?
Yes, go ahead.
Representative Schmidt, after this Conference for Food Protection has been completed, is there any follow-up to know whether this has been successful, whether the education that they get has done what it meant to accomplish, or is there no follow-up at all?
I would imagine that there's no follow-up particularly on this, and it would be, I would imagine, per childcare center or per anyone who serves food to the children. So the follow-up would be every time they have a new person working there, they would need to take a class in this.
Representative Kofalt.
Thank you, Mr. Chairman. Representative Schmidt, I am interested in sort of maybe exploring some unintended consequences. One of the provisions of this bill it says any person employed by and serving food. It perhaps sounds like a silly question, but is there a definition around what it means to serve food? Obviously, if I'm dishing out food onto a plate, that's serving food. If I'm handing out snacks to students or to children, in this case, then maybe I'm probably serving food. If I'm handing them a meal or a snack that has been prepared by a parent, is that the same as serving food? So I guess my question is, does this become a de facto requirement that everyone employed by the child care center must attend this class?
That sounds like a terrific idea to me.
But the bill itself does not address that question of definition.
It does not.
Thank you. Representative Merchant.
Thank you, Mr. Chairman, and thank you for taking my question, Representative. Following up on the question about any person, do you expect all people to be trained, or having at least one person within the facility trained so that somebody there can recognize it and deal with it, versus having everyone within the facility of daycare being so trained?
I would suggest that anybody who is serving the children should have this class. Anybody who is working there that does not serve the children is not required to take the class.
Follow up?
Follow up.
And I'm drawing upon that as far as like in the school system, the nurse is the one trained to deal with these kind of issues. However, the people serving the food in the cafeteria may also not have the training. I don't know if that's the case or not. I'm just trying to look at the scope of the requirement and trying to be ensure that we balance it between the regulatory side of everyone versus having someone there adequately trained.
If you look at what the school nurses do presently within the rule, not necessarily within law, but within the rule that they must follow. It's very strict about what they're training. And I believe that anything that happens within their purview has to be part of this as well. I would say that yes, the people who create and serve meals to children have to have support and understanding of what they're doing through the nurse.
Thank you.
Representative Gay.
Yes, this is really interesting because y'all are bringing up a lot of really important ideas that need to be clarified. I'm kind of interested in, does food safety, how to handle food to keep it safe, that also in this bill, the current rule covers recognizing allergies or tracking allergies, how to handle allergies?
For schools, yes, it does. I have something from the nurses last. I tried this bill, as I said earlier, encompassing everything, and found out that the nurses already take care of everything that they manage. And I did hear back from them with the full list of what they do. But if you check the rules on school nurses and allergies, you'll find that it is comprehensive.
Follow up, yes?
How do you find the rules to check?
There's state rules on education and nursing. It's the state's rules on this.
Yes, ma'am. It would just be really nice to know where that is, because if you could email us the location.
It's at 200:44A. I believe I put that in the document I sent to you.
One more follow-up.
I'm still asking really the same question. I mean the web page to reach that, because that's an RSA, not a rule.
I can send that to you after I do the research.
Thank you so much for taking all of my questions.
Absolutely, not a problem.
Representative Nelson.
Yes, thank you for taking my question. Do child care facilities have nurses normally?
I do not believe so, no.
Okay, so that would not count on a nurse being there to help out on that. My second question, Mr. Chairman, would be, as a former school teacher, while I never served lunch, I have been a principal and in an elementary school, and you do find yourselves sometimes filling in and serving under special circumstances, handing the kid the lunch, or mom brings it in and you bring it to them because they forgot it. So just curious about that. Other school personnel.
I'd ask your nurse if I were you. I think that's where they should make sure that the entire school understands the problems of food allergies. And I think at this point, almost all humans do understand how deadly, say, a peanut allergy can be. I know that there's the woman, the constituent of mine who actually asked for this last year, will be speaking today. She has some testimony she has sent in, I believe, and she has in-depth information on this, as her child has suffering from allergies.
Thank you.
Representative Snow, please unmute and ask your question.
Thank you, Mr. Chairman, and thank you, Representative Schmidt, for taking my question. I assume that all child care centers require the parents to fill out a health history and answer certain questions. Is one of the questions on those forms, does the child have any food allergies, and to ask for other details? Do you know if that's part of the regular record?
I would imagine that any child care center that does not require this would find themselves in courts very quickly. This is simply a matter of protecting the business and all the children at the same time.
Representative Kofalt.
Thank you, Mr. Chairman. Yeah, I guess I wanted to better understand the scope of the problem. I'm very aware of the fact that allergies can be deadly in many cases, and certainly are are a critical issue. I guess I'm trying to understand, to what extent would this training change the situation? You know, if there's an awareness of that already, which I think has been pointed out, does this really change the situation, or is it essentially just telling people what they already know and practice every day? That's my concern. Is there any data on sort of existing incidents, and can you speak to how those might have been avoided by passing legislation like this?
And I don't mean to put it off, but I really think that my constituent has the information that you're looking for, not my guessing, but her knowing.
Representative Schmidt, so that I can, when it's time, call on that constituent. What is your constituent's name, please?
Oh, you're going to ask me that right now, aren't you? Let me go through my notes. Oh, for heaven's sake.
Mr.
Oh,
Chairman,
Sherwood.
I have hands up from the audience from Melissa Clement and Heather Goss, as well
It's
as
Heather. Thank you.
helpful.
Thank you.
Then Representative, may I bring Heather Goss in at this point?
Absolutely. If you're all done with me, that would be absolutely terrific. You guys are really inquiring minds, I have to say.
Well, we're not done with you. We're going to get another shot at you, but we'd like to give you a breather. And, the chair recognizes Heather Goss to present your testimony, please.
Oh, I'm sorry. Good morning. Can you hear me?
Good morning, Heather.
Yes,
Good morning.
Heather. You're on.
Thank you, Chairman Pearson. My name is Heather Gass. I'm a resident of Merrimack, New Hampshire, formerly of Nashua, New Hampshire, as Representative Schmidt had mentioned. And I'd just like to thank the committee for hearing my testimony here on HB 617. I've also emailed my written testimony to the committee, so please refer to that for additional facts as well as some data sources. And I'm here today because I have a 2.5-year-old son with multiple life-threatening food allergies. And I personally have experienced the severe and life-threatening allergic reaction known as anaphylaxis. I'm a working parent and I rely Monday through Friday on childcare. And I've found that the lack of food allergy and anaphylaxis training, as well as food allergy care plan implementation, to be extremely troubling, to say the least. When you have a child with a life-threatening food allergy, seemingly benign things such as milk, eggs, peanuts, or even sesame seeds could send your child into anaphylaxis. My son was only 7 months old. He was an infant when he experienced his first allergic reaction at a child care center right here in New Hampshire. He actually did have an allergy action plan in place from his physician because he had already been diagnosed with a peanut allergy. So an allergy action plan is something that the physician will give you that outlines what to do in an allergic reaction. It does not outline what needs to be done day to day within a daycare facility or childcare program to prevent an allergic reaction from happening. So we made sure to instruct the childcare staff to only feed him food that was brought in from home. And just as a note, especially in smaller childcare facilities, there is not typically a cafeteria or a kitchen. The teachers themselves are preparing the meals and snacks for the children and serving them. So we had told them not to give him anything other than we brought in from home. One day I came by the child care center after lunch. I noticed my son was having an allergic reaction. None of the staff had noticed, other than that they remarked that he had seemed pretty fussy at that time. Immediately I saw that his mouth and chin were covered in hives. And so what I did was I followed that allergy action plan that the staff did have with them, and I gave him Zyrtec. That's the first step. So thankfully he was okay. And thankfully I showed up when I did because I caught the reaction in time before it could have progressed into anaphylaxis. So we did find out after questioning the staff that he was fed another child's yogurt by a staff member that was covering a break in his classroom. This isn't unheard of. I have a lot of friends and family in this allergy community, and this happens more than you'd think happens. I just want to be really clear here. So this reaction happened even though they had been instructed only to give him food in bottles from home, and he already had an allergy action plan in place for his other known allergy. There was another occasion where 2 staff members who were in charge of caring for my son could not find his EpiPens when I had asked about them. I actually had to instruct them on where to look. Now, this is something that all staff is supposed to know at all times where those medications are in case of an emergency. So you can imagine if my son happened to have an allergic reaction and these 2 staff members were caring for him, staff members that again have been through the CEUs for allergic reactions, CPR and first aid, they could have been really bad. They didn't know where the pens were. I just want to mention that because every second counts in an allergic reaction. Somebody can go from a minor reaction to severe anaphylaxis within minutes. So that's why it's really important to know where those EpiPens are at all times. So as you can imagine, all of these events had left me angry, scared, and anxious every time I needed to leave my child in someone else's care. So while this bill, HB 617, does take the first steps of training childcare staff in food safety and things like cross-contamination prevention, I think we really need to do more to protect our food allergic children, especially infants and toddlers who cannot advocate for themselves. I have read through the New Hampshire childcare licensing rules, which are available on dhhs.nh.gov many times. And these are the rules that govern how childcares are licensed and the rules that they need to follow in order to keep that license active. There are a few key things I'd like to point out that we really need to fix with this. And I'd like to, if I can, just follow up on a couple of points from some of the other representatives. To follow up, excuse me, for Representative Merchant and Representative Nelson, childcare centers are actually not required to have a nurse on staff. So this differs from a K through 12 situation. The staff is required to have CPR and first aid training, as well as a few other CEUs that are listed in that childcare document. But just so you know, they're not required to have a nurse on staff, and the majority of them do not. To Representative Kohlfeldt, every single childcare teacher that I've ever seen serves food to children. As you mentioned, it could be just serving a snack, it could be serving a full meal, but every single person that works with the children in those facilities do have interactions with food and serving kids food. So that's why I think it's really important that it's everybody that gets this training. To Representative Snow, yes, you do fill out a form when your child does start at a new childcare center. They do ask for allergies, but the problem is that, excuse me, every daycare or childcare program manages these things differently. Whether or not they put a plan into place is different from center to center. And I'd just like to point out a couple of holes that I've seen within these childcare licensing rules and why I think this training plus some anaphylaxis training is very important. There's actually a PowerPoint style presentation that is part of those CEUs that everybody in the daycare has to take. The problem with that, it does not review the various types of epinephrine auto injectors and how to use them. So there are about 6 or 7 on the market. Some people are familiar with the standard EpiPen, but there are others that have slightly different ways of using them. So it's very important to understand those differences. And like I mentioned, the training that they currently take does not cover all of those. It also doesn't require a passing grade. So participants can click through the slides of this training, can complete the training without reading the information. In comparison, first aid and CPR training actually requires hands-on experience and a passing grade. So anaphylaxis training, as it is a part of something that is addressing a life-threatening situation, it really should be the same, that they have to have a passing grade. A couple of points about food allergy and anaphylaxis training in general that aren't covered by the current rules. Any food allergy and anaphylaxis training really should train caregivers in how to prevent exposure to food allergens, including food preparation, which this bill does cover, and how to recognize the symptoms of an allergic reaction and anaphylaxis, and also how to treat allergic reactions, including one of any of the types of injectable epinephrine that are available. And then the other piece that I'd like to mention here is with food allergy care plans. So a food allergy care plan is something that's specific to each child and should include steps to prevent contact with food allergens. So this is different from the plan that comes from the doctor that tells you what to do in case there's a reaction. So currently there's a vague guideline in the rules that really needs to be expanded. I think that we really need to have a requirement that these plans are reviewed and signed off by all staff. Typically, if they do create a plan. It's posted within the classroom, but everyone is not required to read it. Where that comes into a problem is if there are different childcare staff members that are covering breaks in other classrooms. If they have not been familiar with that plan and they're serving somebody a snack, they could potentially serve something that the child is allergic to. And that's exactly what happened to my son. Also, there's no predetermined format or outline. So we've had experience with a few different childcare centers and we've had to provide something to them each time. So this is a problem because if there are multiple children in the same classroom with food allergies, they could have different formats on the plan, and it just makes it that much harder for the staff to kind of go through and understand what they need to do to keep the children safe. So I really hope that the committee here considers supporting HB 617 and potentially amending it to include required food allergy and anaphylaxis training and requiring more comprehensive food allergy care plans for childcare programs. And I'm happy to answer any questions that you may have.
Ms. Gass, do child daycare centers, do they have the requirement to have EPI or equivalent things on site?
No, not as a standard requirement. So the problem with an EpiPen typically that I've seen it within legislation is that it does require a prescription. So typically what happens is if your child has an allergy, the physician prescribes the epinephrine auto-injector, and then the child has the care plan that's on file with the daycare that they have the EpiPen kept at school, and then they can, or at the daycare, and then they can use it that way. But there is no global requirement for stocking epinephrine in childcare centers in New Hampshire.
Is there a requirement for the stocking of such devices if a child is present who would need one?
No, that has to come from a prescription from a physician and then be brought to the school that way. The school themselves, the child care center, as far as I know, cannot request a prescription for just any type of use of a epinephrine auto-injector.
Thank you. Representative Woods.
Thank you, Mr. Chairman, and thank you, Ms. Goss, for taking my questions. Are you familiar with this course conference for food protection? And as a second part to that, if you are familiar with it, had the staff attended such a class, would that have alleviated the issues that you have identified relative to your son?
Great question. I have briefly looked into this and I am by no means an expert on it. I think that the training potentially could have avoided my son being served a yogurt that was not his. I don't think that it would have helped in the issue of having the staff identify that my child was having an allergic reaction, and also would not have helped with the issue of the other two staff members not knowing where those EpiPens were. I do think that the bill is important to show cross-contamination and make sure that people understand that, and that's what that training would partially provide.
Representative Acton.
I didn't have my hand up. I don't know if that's still from before.
It is from before. If you have
Yes.
had your hand up and you have asked your question, please take your hand down. Representative Nelson.
Thank you, Mr. Chairman. My question would be bus drivers. I don't know if preschool kids get bused or not, but if they go to kindergarten, they are bused. Do bus drivers have to take some of this, a course like this? I mean, a bus driver I know will give out things for Christmas and may give the kids a little candy or something like that.
That's a great question. As far as I know, and in my experience, I have not come across a child care center that uses buses. I know in K through 12, this issue actually came up last year with the Education Committee with the previous bill that Representative Schmidt had mentioned that tried to cover that. And no, in New Hampshire currently, bus drivers for K through 12 are not required to have any type of allergy and anaphylaxis training or EpiPen training.
Thank you.
Mm-hmm.
Representative Gay.
Thank you, Mr. Chairman, and I'm sorry that I'm not always polite. I forget. Because I also had a child with many food allergies, I'm really sensitive to your problem. And I'm thinking all these additions to the rules sound really good, the education especially. And I'd like to suggest too that there be something children can wear that says what they're allergic to, because when people are taking care of multiple children, obviously they can be distracted and forget which child is allergic to which. So I'm just thinking something appropriate that they could wear on top of their clothes or pinned to their clothes that wouldn't be a problem for another reason might be a life-saving thing, just to catch people's attention that if they don't know what that child's allergic to, it's a reminder you better check, and also be looking at the child to see if they're reacting to something.
Representative Chairman Pearson, do you mind if I answer that? Or
Please do.
Comment on that. I think that's a great idea. That's something that personally we've implemented. My son wears a little yellow band that shows what he's allergic to. It's definitely at this point not a requirement, and I think that would be a great addition to the food allergy care plan as something that the schools could have in place to make sure that everybody knows what the child's allergic to.
Ms. Gass, might that be an optional thing? Because I could think of scenarios where a child wearing such an indicator could subject the child to some taunting from other students.
Absolutely.
So might that be something to be considered on a case-by-case basis?
Absolutely. And I think just with my experience with other parents, some parents are more sensitive about it than others. I would say the majority is more concerned for the child's safety, especially when they're in the infant and toddler stage where the bullying and the comments may not be an issue. But I absolutely would agree with you that that should probably be something that would be optional.
Representative Nelson.
I do not have a question.
Please take your hand down.
Okay.
Thank you. And I'm going to call on Representative Merchant, but I don't see him, so I think that's a leftover hand. But if it isn't, Representative Merchant? Okay, Representative Weber.
Thank you, Mr. Chairman. And Ms. Goss, I wouldn't have normally asked this of a member of the public, but you seem to be very familiar with our licensing rules of necessity. And for that, we thank you for your expertise. I'm going to put this in the form of a question. Is it not true that there's a difference between the statute, the law that we are looking at today, which perhaps ought to specify the broad areas that we need rules on, like food safety, allergy recognition, safety plans, that sort of thing, which could be put in the rule, and the specifics of what is required for daycare, which ought to be done by rulemaking, which is for the department and not for us. Is that a reasonable separation of separation of responsibilities?
Yes, I would agree with that. I would also mention that I have reached out to DHHS, to the child licensing coordinator, a few times with my questions, and sometimes the answers that I've received back kind of led me to believe that they are not fully familiar with some of these struggles that we're having. So I think really understanding which side this falls on, whether it be on the legislative side or the rule side, is definitely something to be determined. And I definitely don't have the answer fully to that.
Thank you.
Follow up.
Mr. Chairman, could I just make a statement to the committee, if you would permit me?
Well, what you just said was actually a question, so that was a lead-in. Go ahead.
I know, but now I'm going to do something that's normally inappropriate. The issue is that they cannot make rules unless we pass a statute. And so for those who are new to the statutory and rulemaking process, the department can't make any rules unless they are authorized to by statute. So if we pass a statute that authorizes them to make rules in this area, then they must make the rules. But without a statute passed by us, they cannot make rules. And I just wanted to make sure that everybody on the committee understood that and understood the difference. But it seems to me that we as a committee don't need to get down into the weeds of exactly what the regulations are. We just need to figure out what needs to be permitted and then leave it to the department. And I thought that might focus us a little bit more.
Representative, that's very, very helpful. And one of the reasons we do that is because sometimes the details change. And therefore, we would have to go through a long process to change the law. But if we have the broad tenets in place, then the rules may be amended very quickly within the department. So I think as we eventually come to closure on this bill, we would want to broaden it, but only in these general terms. Thank you for that very much. And when the parties flip and you're the chair again, and I'm just a guy, I will remember that occasionally it doesn't have to be a question. Thank you for the precedent. Representative Woods.
Thank you, Mr. Chair, and thank you again, Ms. Goss, for taking my question. Would someone be able to send us a syllabus on this conference for food protection course, so we have some ideas? I think that would be helpful to understand exactly what is the content. And as a sidebar to that, I heard you, and if you could clarify, you said something about not needing a passing grade. Was that relative to this particular course or something else?
That was relative to a different course. So there is what they call a CEU for food allergy training that the daycare staff is required to take. And it is basically just a click through PowerPoint. I've actually gone through it just to see what it was myself. And technically you can click through it without actually reading the slides, and it will mark that you have completed it. That is in comparison to a CPR or first aid class, which requires a passing grade in order to be certified. As far as your question regarding the actual training, I can do some additional research into seeing if we could get that for you. And I think also Representative Schmidt could do that for us as well.
Representative Knurk.
Yes, I just have a real quick one, follow up on what was just said a moment ago. Rather than getting down in the weeds about which course and putting that into statute, could we not just give the authority to DHHS and rulemaking to approve an appropriate course and not prescribe that here, because that might change. This organization may go out of business. Would that also be, and I'm asking this maybe more as a question to the chair, would that be an acceptable way to handle this?
Let me hold off a little bit about going forward, but I think that's a great suggestion. Thank you. Welcome back, Representative Marsh. You're recognized to speak.
Thank you, Mr. Chairman. I just wanted to state for the record that I am present and home alone in my home office in Brookfield so that we are compliant with 91A.
Thank you, sir. Anyone else with a question for Ms. Gass or Representative Schmidt? Because we have a few members of the public who wish to speak. Seeing none, thank you both very much.
Thank you. And
the chair recognizes Melissa Clement to speak.
Good morning, Mr. Chair.
Good morning.
Good morning, and members of the committee. I'm Melissa Clement. I'm actually the chief of the Child Care Licensing Unit at Health and Human Services. So I think I can help address some of the issues that have come up and provide some clarity there, and I'll answer any additional questions that you may have as well. For child care licensing rules, we do require that any staff who are responsible for supervision of children or being used to meet staff-to-child ratios, they do have to complete a training on the prevention of and response to emergencies due to food and other allergic reactions. So we do have that training. I understand that Ms. Gass spoke to, I'm not sure which training she took. The department allows trainings in that broad topic. We provide through the Bureau of Child Development and Head Start collaboration a free training from Pro Solutions that addresses that topic. And you need to have at least a passing score of 80% in order to mark that as complete. So you're able to go through the course, you're able to repeat the sections where you didn't get the questions correct. And once you get an 80%, you have passed that CEU and you get those training hours. In addition, our rules address underneath our prevention and management of injuries and emergency section, HE-C 4002-19F. And each child who has a food allergy or other allergy that results in a serious reaction shall have a written care plan that includes the instructions regarding the foods or other allergens which the child is allergic to and the steps to be taken to avoid them. A detailed treatment plan to be implemented in the event of an allergic reaction, including the names, doses, and methods of prompt administration of any medications, and specific symptoms that would indicate the need to administer one or more medications. And then at least one child care personnel supervising a child with an allergy care plan shall have completed that training, because you do have 90 days to complete the training. So we also take the additional step that if it's a new staff, you still have to ensure that any staff with a child with an allergic care plan has taken the training. So there isn't anyone there who's not trained. And then each child's care plan shall be posted prominently in the child's classroom and whenever the child may come in contact with the allergen with permission from the parent. So those are the steps that we've taken in our rules currently to make sure that children with allergies are identified, that the staff understand what it is they need to do and how they need to follow through, and that they have to have training. And also with that, they also have to have first aid and CPR certification as well. That's a requirement for all staff in childcare programs. Underneath our statute, RSA 170E-11, which is our rulemaking statute, under the provision of 1E, it allows for provisions of food, clothing, educational opportunities, program equipment, and individual supplies to assure the health and the physical and mental development of children served. So that is this rulemaking statute that we use when we're addressing the needs of children and their health needs. And with that, I'll turn it back over to you guys and I'll answer any additional questions you have.
I have a question for you, Ms. Clement. Given what you've said, is this bill necessary? And there's a follow-up to that. Let's start with that. Is this bill necessary then?
I believe that when we look at our rules, there's always room for improvement. I think that we've addressed them in our rules and we can certainly tweak the rules that we have. But I welcome any suggestions from the committee to make sure that the children are safe.
Then my follow-up would be, based on previous testimony, I believe, from Representative Weber, are there statutory provisions that you need or would like, or both, to help you in areas of rulemaking where the statute is presently silent?
At least in regards to food allergies, I don't believe the statute is silent. I believe we have the statutory requirements we need in order to address that in our rules.
So while there's always room for improvement, your testimony seems to answer the concerns that people have brought, would you say?
I believe that we have, based on the testimony I heard today, I think we have sufficient rules to address the concerns. I certainly want any parents to reach out to us if they've had a concern in their child care program so that we can address those specifically with each child care program. There's always, unfortunately, going to be times when a program may not be sufficiently aware of what it is they need to do, or there's ways that we can assist the individual programs. But I think broadly our rules are there to address those concerns.
Thank you. Representative Snow.
Thank you, Mr. Chairman, and thank you for taking my question. I'd like to ask the woman from DHHS, whose name I didn't catch, but maybe you could give me that too. But you said that the care plan for responding to somebody that has an allergic reaction, you need to write that plan up once the child has had an adverse reaction to some food product. Does that mean you don't have a care plan for somebody who the parents report a food allergy, but they're not required to do the plan until it happens at school? Or is the way that thing is worded, it just says if they've ever had a food allergic reaction, either at home, in the community, or at the daycare, that this action plan gets developed? Am I clear on the question?
Yes, thank you, Representative Snow. And my name is Melissa Clement. I'm the chief of the Child Care Licensing Unit. So the rule, I read through them pretty quickly, but the way the rule is written, it says each child with a food allergy or other allergy. So you can't write a care plan if an allergy hasn't yet been identified, but that can be identified before they enter the childcare
Okay.
program. It doesn't need to happen at the program.
Thank you very much.
I'm going to bring Heather Gass back. She has her hand up. I think she may be wishing to speak to the question that was posed. Heather Gass, you're called up.
Thank you. I just did want to point out maybe a couple issues here, and maybe Melissa, you'd be able to clarify. So to that previous question about addressing children who already have an allergy and having a care plan for that, I guess I would point out that one of the holes is that, especially in my child's case, he had a reaction to something that he had never had before. And I've seen this with friends and family where children have their first allergic reaction within the child care program, and there's no current plan within the rules to address that, other than the first aid and CPR training and that initial food allergy training.
Thank you. The chair would now like to recognize Rosemary Rung, who has her hand up.
Good morning. Can everyone hear me okay?
Yes, we can.
Thank you. For the record, my name is Representative Rosemary Rung. I represent Merrimack, which is Hillsborough 21. I became quite knowledgeable about the whole area of food allergies about a year and a half ago when a constituent asked if I would pursue legislation to expand food allergy awareness training to restaurants that fall outside the jurisdiction of the Department of Health and Human Services. Many communities in New Hampshire are licensed by the state, but there are very many that are only licensed and inspected by their local jurisdictions. So they are exempt from following the New Hampshire Food Code. Now, back in 2017, the US changed their food code to require restaurants to have a food safety manager on site at all time. New Hampshire adopted the US Food Code that same year and put into their rules, which is HEP 2300, the requirement of food safety managers for New Hampshire restaurants under New Hampshire state jurisdiction. My bill would have expanded that requirement to restaurants that are only in local jurisdictions. That law was titled Rachel Hunger Law, after the young female student at UNH who died from an anaphylactic reaction at a local Durham restaurant. It was a Chinese restaurant she had frequented often, but they had changed their recipe for egg rolls, unbeknownst to her, which now included peanut paste, and she was allergic to peanuts. So this bill passed the committee, and it went to Commerce. It passed the House on a voice vote, but it got hung up in the Senate due to COVID delays. That bill has now been reintroduced, and I'll be testifying in front of Commerce at a date soon to come. But during
Representative, this bill is about childcare licensing, and we're already way behind.
Oh, okay,
Please
well,
move
let
to
me
the bottom
hurry
line.
on. Okay, but in the course of that research, I learned that 4 to 8% of children in the US suffer from food allergies, and that number is going up. The training that they would be able to, the childcare workers would be able to have is also the same training that's now being offered and extended through restaurants throughout New Hampshire. And it's under a company called ServSafe. And it's one of the few training modules that is recognized by the Department of Health and Human Services for restaurant licensing. It takes about it could be an 8-hour module or a 16-hour module. There are 3 different types. There's in-class, virtual, self-study. I think if this bill passes, there would be a lot of synergy between offering this training to childcare workers, along with the New Hampshire Restaurant and Lodging Association, who drives a lot of the training management for their members in the state. And it's about $200 to take it. That's for the highest level of training. There's different levels: food safety manager, food handler, and goes on. But as a co-sponsor of this bill, I support it 100%. I think that it fills in the gap between actually giving a child food, but then preparing the food and recognizing those things which can set off an anaphylactic reaction. often it's very easy to, let's say, substitute flour for cornstarch, or a product, a packaged pancake mix, for instance, that may have dried egg solids in it. So the training enables people to be able to recognize sources of allergens and how they interact. But thank you very much for this opportunity.
Thank you, Representative. Seeing there's no more hands up, either on the panelists or under the attendees, I'm going to close the hearing on House Bill 617, and I'm going to make a suggestion. Many of us do not want unnecessary regulations. However, I think many of us are quite aware that some regulations need to be made. And so the question is this bill necessary as it is? Or are there a few things that should be in statute that aren't, whereby we may help DHHS to do their work? And so what I'm going to suggest, Representative Schmidt, thank you so much for raising this issue. I have personal allergies and experience with anaphylaxis. I have dear friends who are of tender age who have the same. And so I am very aware of the situation. So what I'm going to ask Representative Schmidt is you have a much further conversation with Melissa Clement from DHHS, find out where the gaps are as the department sees them, as you see them, and perhaps come back to us, either suggesting the bill goes forward as you've given it to us, or perhaps withdraw it or ask us to ITL it, or third, come back with an amendment that would round out everything we've discussed today. And certainly anybody here is free to call you with their input. This would normally be the kind of thing where we'd have a nice work session, but we're coming up on crossover deadlines fairly quickly. We have a lot of bills and we don't have a lot of available computer time. So we're getting the word, minimize work sessions, subcommittees. So Representative Schmidt, I'm going to suggest that to you. And with that, the hearing is closed and we will move on to our next item. And this should take a while. Gavel. I open the hearing now on House Bill 602, relative to reimbursement for telemedicine. And I'm going to call on Representative Jess Edwards from Finance Division 3 and an alumnus of the greatest committee in the House, both to introduce the bill and also speak to the amendment. And this is important because we have gotten, I think this is a technical term, bazillions of emails about certain aspects of the bill as originally submitted that the amendment may address. So Representative Edwards, would you please introduce your bill and speak to the amendment?
I will. Thank you, Mr. Chairman. Good morning to the members of HHS-EA. I'm Representative Jess Edwards representing Auburn. I think for this conversation, I need to remind some of you and tell some of you about my background. I've been a healthcare informaticist for a couple decades. When I was a clinical manager at West Virginia University, I implemented teleradiology there. That was a pretty early implementation for the era. From there, I moved to become the deputy program manager of the telemedicine test bed in the mid 90s. And I was an instructor at Georgetown University during that time frame. I wrote a textbook chapter on military telemedicine, along with several articles, and spoke at many national conferences on the subject. From there, I spent 2 decades as a product manager meeting customer needs with digital imaging. So I worked with engineers and technologists to put together emerging solutions to meet clinical needs. Then, as a member of the House, I was in 2018 a member of the Telemedicine Healthcare Reimbursement for Telemedicine Telehealth Study Committee. That was chaired by Senator Jay Kahn. And we found some interesting things in that study that we did, and it's been published. It showed what we learned was that Medicaid was lagging way behind the commercial insurers for covering telemedicine. And certainly if they weren't covering it, they weren't reimbursing well. So Senator Khan and I, with others, introduced legislation to have Medicaid catch up to the insurance companies. So, hey, there's emerging clinical practice out there that Medicaid is not up to speed on. So let's get going. Well, then something funny happened. We had and I don't mean funny as in humorous, but quirky. We had a pandemic that motivated on the 18th of March of 2020, the governor to issue an executive order that said we were in a state of crisis and that we needed to preserve our healthcare system. And a key strategy for doing that was to find ways in a crisis mode of keeping patients out physically from clinical settings. And so the governor's team opened up the spigots and said, go forth, do as much telemedicine as you can. Telemedicine from this point on shall include audio only, so telephone calls can be reimbursed the same, must be reimbursed the same or better than in-person care. So clearly the pandemic response was, let's not worry about the fiscal notes. Let's not worry about the monetary impacts. We have to preserve our healthcare system, have patients get their care without having to come into the facilities. So it really made a lot of sense. So with this bill, and more importantly, the amendment, and I'm going to really talk about the amendment because the bill, I think in retrospect, with all the feedback I've gotten half a bazillion comments on it. The underlying bill itself was kind of a mess. So I submitted an amendment that is really pretty clean. What it does is it says that the state is going to become agnostic on what the reimbursement rates ought to be for in-person care versus telemedicine. That we are not going to be in the role of setting or fixing prices. It waits for 180 days after the executive order has expired. I picked the 180 days to give clinicians an opportunity to transition their patients from the kind of care they've been getting for the last year and more by the time this is over to what they consider the appropriate standards of clinical care in the aftermath of the pandemic ceasing. So for all the people who are concerned, we can't do this in a pandemic, I agree. We're not going to do this in a pandemic. For those of you with eagle eyes and who are looking at the amendment 2021-0195 hotel, if you look down under applicability, it does it pretty good. The OLS people heard me. They said, we're going to make this effective after the state of emergency is over. But where there was a mess up is she did not put in the 180-day transition. So I've contacted her, Courtney Eschab, I think her name is.
Eschelbach.
Yeah, and she recognizes that the 180 days went missing from the amendment. So I apologize to the committee. There's an amendment to the amendment coming, but so the two things it does and the one thing it does not do is the two things it does is it will wait. It waits until after the state of emergency is over, and it creates a grace period I think of 180 days. If the committee thinks it should be a different number, that's fine. And also it breaks the connection between the requirement, the mandate to reimburse telemedicine at the same or higher rate than they do in-person care. That's an artificial edict that makes sense in a crisis, but does not make long-term sense. And then the thing that this does not do is this bill does not in any way step on the special provisions that we need to deal with the pandemic. We take a breathing period after the pandemic before this bill takes effect. So for those concerned about the pandemic, I assure you this bill has nothing to do with that. And because I've gotten a whole lot of messages saying that I'm being short-sighted, I want to assure people that I'm actually being very long-sighted. My vision of telemedicine really started in the 1960s with Reba Benschutter and Cecil Whitson, who I got to know as a young teenager. And I got to understand the telemedicine program that they put in place with the Nebraska Psychiatric Institute between Omaha and Norfolk. I know from then and from reading about it that the technology hadn't really been invented just a year earlier. It was AT&T's invention of some critical components that even made it possible. And so the University of Nebraska Medical Center got interested in telemedicine, even though it cost $1 bazillion more than in-person care, because they had a clinical research component to it. But if you go back in time, telemedicine has been really, really expensive, and the price points are coming down rapidly. I think it's analogous to a lot of the arguments people used to have about canals and railroads. They were both ways to transport goods from supply centers to population centers, and there was a great deal of competition. The government tended to favor canals, private industry tended to favor railroads. It's this bill where we've said that the price mechanism between telemedicine and in-person care is sort of like if at that time when canals and railroads were finding their place in our transportation network, that somebody had issued an edict that said 1 pound of coal shall be charged the same amount for transport regardless of the method of conveyance.
Representative Edwards, we're way behind in our schedule. Would you please focus on just the high points without the history, as much as I love history, and wrap it up? Thank you.
Mr. Chairman, the reason, yes, sir, I will, but the reason I'm belaboring it is because disconnecting or freeing up the pricing mechanism is the core of this bill. And there will be people on the committee who will want to keep the pricing mechanism locked up to ensure telemedicine and in-person care forever more shall be mandated in the statute as it is today. And it's those people I'm trying to speak to say, please think of this differently than what you have been. The pricing mechanism is essential to sending market signals to investors and others because we have an entire re-engineering of the healthcare system in front of us. And we have rapidly emerging technology that's going to give us a tremendous number of options we've not had. So I'll skip down at your request. Let me skip down to a key part of this. You may want to take a look at my testimony. I sent it in last night. Hopefully it reads like an interesting academic paper. But one of the things I wanted to point out is that technology changes things initially by substituting one approach for another. That's where we're at now with telemedicine. Instead of traveling, instead of doing traveling to the in-person care, we can virtually travel. Well, what's going to happen as this evolves is there's going to be a period of time where increased coordination, because of the technology is in place, will start to happen. So you'll start to see people who worry about coordinating social determinants of health, for example, be able to do person-centered care much more effectively. There'll be enhanced abilities to communicate with people throughout the community and throughout the state. That's because the technology will begin to be more familiar and be more leveraged. What the third order effect is when we totally create new methods of providing clinical care. So like with the advancements in wearable biotech and ubiquitous communications, what we're going to see in a few years is the constant transmittal of your personal medical data to a storage center where there will be artificial intelligence applying smart algorithms to determine whether or not the person has remained within specs. If you get thrown out of standards, you go from being a person to a patient. The watch can send an alert saying, hey, you need to go see somebody now. We'll be able to tie that to GPS. We'll be able to tie that to scheduling software and to geolocators to say, you need to go see someone now. And oh, by the way, there's a person 4 blocks away from here and they're available right now.
Representative Edwards, I'm going to cut you off right now. We have in this committee, as you should know, enough people for me to staff a medical center, a counseling center, and a pharmacy. So I'm going to suggest now that they ask you questions, because a lot of what you're saying, most of us know very well from living it.
Okay.
Representative Shapiro, please. Please unmute.
I guess the space bar didn't work. Can you hear me now?
Yes, we can.
Thank you, Mr. Chairman, and thank you, Representative Edwards, for taking my question. It seems to me like part of your agenda here is not to pick winners and losers, and to be open to which services are more efficient and effective. And yet your amendment seems to say that video telehealth will be covered, but audio will not necessarily be covered. Now, we have received many emails from lots of people, but I think a majority of them have been from substance use disorder treaters and mental health clinicians.
Yes, sir. So if I may, are you looking at the amendment 0195 hotel?
I think I am.
So look at line 14, where line 14 it says audio, and it deletes the reference to audio only. I have left audio only as an option where the government doesn't need to take a position on when audio only is good clinical care.
Right.
Like, for example, I have diabetes. I had a phone call where the provider went over my readings with me and we talked about it. She determined whether or not I needed a change in medication. All of that was good clinical practice over the phone. But if I had needed to see my ophthalmologist to determine, progress of my eye surgery, I probably would have had to go in person. So some things are open to telephone calls, some things are not. This bill stays neutral. It stays out of the discussion.
Follow up, Representative Shapiro. Follow up.
Well, I haven't asked my question yet. So it appears to me that audio is an option, but it's not one that's mandated. And I'm wondering, and video and audio are mandated. So my question really is, Do you have research? Do you have data that says that audio only is less effective than audio video? And do you also have research which might talk about the number of people that have been able to access services through audio only that would not be able to if there was not audio only mandated?
I'll address that, but I first need to just say that we have an interpretation difference. I think lines 13 through 15 do the opposite of what you suggest. I think it includes audio only as a reimbursable option. What this bill is trying to do is to get out of the micro management of exactly which clinical services can be done over the phone and which ones cannot. I think you would agree with me that there are examples that you and I can think of right now where telephone only is okay. But there are other examples where telephone only doesn't do it. It's not adequate clinical care. So it's not up for us to mandate reimbursement in a situation where the clinical effectiveness can vary between different clinical requirements. So to your other question about, am I familiar with research? Well, I know that clinical efficacy research in various aspects of telemedicine have been taking place for 20, 30 years. So depending on what specific clinical subspecialty you're looking at, you would have to burrow into the available research to see whether or not that particular clinical question has been asked.
Follow up, Representative Shapiro?
I will defer to the next questioner.
Thank you. Representative Folsom. Unmute, please.
Sorry about that. Thank you, Mr. Chair. Thank you, Representative Edwards. I just want to clarify something to make sure I'm seeing this properly. The concern that was raised in most of the people that contacted me through email was that they felt they would be limited to audio or video only. However, it reads now in your amendment that the coverage will be for all modes of telehealth, including video and audio and other electronic media. So that whole concept of them having to have video, I'm reading that has been taken out and dismissed and that people will now be able to use just audio.
That is exactly my intent, Representative Folsom. I did get a lot of feedback, and it was pretty clear that the audio only issue was causing a great disturbance, and so I've gotten the government out of making those incremental judgment calls. That's up to the clinical efficacy research and decisions by others.
Thank you. Representative Cannon.
You're on mute.
Please unmute.
The space bar didn't work. Thank you, Mr. Chairman. Representative Edwards, I'm going to give you a situation I encountered, and you can help me understand how this bill would impact the two different situations. I went to see a pulmonologist. I believe that's the term. And the first time I saw him was an in-person visit. And so I understand that the charges would be for an in-person visit. The second time I went to see him, the COVID rules were in place, and I went to the office. I was brought to a treatment room, and where the nurse took my weight and blood pressure, and then told me to wait for the phone to ring. Where I answered the phone. It was my physician. We had a conversation, and when the conversation was done, they let me leave the building. He charged me for an in-office visit. Another month or so later, I had a telemedicine call, video and voice over my telephone, to ask basically the same questions I had when I was at his practice during my second visit. So would all three of those situations be charged the same under your bill?
So thank you for the question, and I hope you're feeling strong and robust, and the pulmonologist is helping you with all of that. But,
I have asthma, by the way.
so I would say that it depends on the time frame we're talking about. If we're talking about the time frame that begins 180 days after the EO is vacated or expired, then the ability to charge and be reimbursed by the insurance carriers would be based on their independent assessment on whether or not the visit met clinical efficacy standards. And not being a pulmonologist, but kind of imagining what sort of questions you were being asked, it would just seem to me that the pulmonologist perceived that he or she was able to provide you good care through video conferencing without you physically having to travel for a weigh-in. And I think that would be fine. I think reimbursement for that is great. I want to see healthcare much like the way we do banking these days, where we do far more of it online at midnight than we do in person at the bank itself. So I would think that what this bill says is we don't tell the insurance carriers what to do. We just say, here's an issue, you guys work it out. And I think that sort of market mechanism is what's going to rationalize the system the best over the long term. Does that answer your question?
Not quite. Could I follow up?
You may.
In both the second and my third visit, both of those situations were only voice conversation. In the in-office visit, I didn't even have a video with my physician. My last visit, I actually had a video. So my in-office visit, I am assuming would be paid by the insurance company for an in-office visit. The third situation with essentially the same questions, but over my telephone, were essentially the same, but I was out of the office. So you're telling me I would have, after this bill goes into place 180 days after the EO, that then I'm at the mercy of my insurance company as to whether I would get reimbursed at the office rate or not. Is that what I'm hearing?
Well, Representative Cannon, that's probably what you're hearing. That's not what I'm trying to say, though. I don't think insurance companies are merciless, so I wouldn't use the term at the insurance company's mercy.
I do.
I would just remind you of what the 2018 telemedicine study found, which was that commercial insurance carriers were doing a vastly better job of covering and paying for telemedicine than the state was, and that our goal in 2018 was to get the state to catch up. The government was the problem, and that was just 2 years ago. And so I think insurance companies have a built-in incentive to build the right healthcare system to take care of patients. And so they're looking at cost, access, and quality every bit as much as any other player. So I only just would take issue with the terminology. But the intent is this would get the government out of that decision. It would allow the insurance companies to act like a free party in the healthcare system.
Thank you, Representative.
Representative Knurk.
Thank you, Mr. Chair. Representative Edwards, I just have a question. There's a phrase you used 3 times because of the 3 different types of coverages. And that is where you refer to a criteria of good clinical methodologies based on research or accepted practice. So I was curious, you alluded to it a little bit before, but do we have this research? And if so, can you give reference to that research? And could you perhaps clarify who makes the decision regarding which research or practice is accepted?
Okay, thank you, Representative Knurk. I would say that the research in telemedicine is much like the research in any clinical subspecialty. There is not just one source, one database where the research gets filed and gets sent. There's not one arbiter of all known research in any of the clinical subspecialties. There are associations that tend to be expert. There are telemedicine associations that one can join to where they can obtain regular newsletters and the like of telling them what's going on in telemedicine research. So telemedicine is as viable an academic research area as any of our clinical subspecialties, in my view. At least that's the way it was, when we were the telemedicine test bed. There was research being done in Hawaii, Medical College of Georgia, University of Virginia. It's just being done in a highly distributed manner, like all academic medicine. And I forget the second part of your question.
You may
May I
follow up
with that?
Yes.
Well, that is exactly my question, because there is no one standard. People will disagree. So my question is, who makes that decision? Because somebody has to actually make that decision to implement these rules that you're kind of discussing here. Who has that power? Because that's not stated that I can see in this.
Okay, so back in the olden days, when I was representing positron emission tomography and how we would apply PET to various clinical scenarios, we would do studies. We would have our academic nuclear medicine people look at it. If we determined it was efficacious, I was the one that would go to the Blue Crosses and Blue Shields and say, this is the care we're providing. You're not reimbursing us for this. Here's our medical research. Would you please begin to reimburse us for this, because this is better than the alternatives. And the Blue Cross and Blue Shield as an independent payer would consider what was being said and would decide whether or not to reimburse us. Fortunately, we ended up getting a lot of yeses, and PET today is an extremely viable part of nuclear medicine, but it wasn't always that way. And so those same sorts of dialogues with payers who are free to choose and to think and to participate in the healthcare system, I think can make those decisions without government telling them how they must decide. Does that answer your question?
Well,
I mean,
so you're saying that the authority rests entirely with the insurers. Is that the answer?
Well, this bill primarily gets the government away from telling insurers what they must do. So the effect of this bill would be to let insurers decide what they think they should do. So like any good argument, I think the good argument will win.
I'm going to ask a question. This bill will let insurers do what they want to do. I would guess the Senate should continue under any new rules and regulations state insurance departments adopt. Is that correct?
I didn't follow your question. I'm sorry, Mr. Chair.
I'm asking, you said this bill would let insurance companies do what they want. I would suggest that would only be under the control of the state insurance departments, correct?
Yes, sir. I assume that is understood. Yes, we have.
Okay, we
a
have
Department of Insurance.
we have somebody from insurance in the batting order here. My second question is, as part-time CEO of a medical counseling facility, many of the telemedicine encounters, many of the telephone only encounters occur from our physical facility, which we still have to pay heat, light, rent on, still have to have a supportive staff. So the idea that telemedicine might give insurance companies the wicked thought of reimbursing at a lower rate than an in-house, in-person visit makes me as frightened as the several thousand people who emailed us. Would you comment on that, please?
I would say that I would generalize your point to be the cost structures of inpatient care or in-person care and telemedicine. Those cost structures are fundamentally different. Yeah, there are some overlaps, but the cost structures are fundamentally different. It's because those cost structures are different that I think the pricing mechanism ought to also be adaptable to accommodate the relevant cost structures. So again, I don't presume the insurance companies to be an adversarial part of our healthcare system. Prior to 2018, they were reimbursing for telemedicine at a much better rate and much more coverage than the state government was. So I think we should have a little bit more faith that clinical reengineering is essential. The technology gives us new tools that we don't have. There will be newer tools and more reengineering that can take place in the future. I think we need an adaptable, flexible system. I believe this bill does that.
All right, one more for me before I turn it over to others. As a person who is a strong believer in having a great deal of faith, I also know that I have to hire a person on my staff because it is adversarial. And sometimes we have to fight for what is right. And we tie up and waste a lot of money going into a battle that shouldn't be fought because it is adversarial. That is not a question. And I'm now going to call on Representative Woods.
Thank you, Mr. Chairman, and thank you, Representative Edward, for taking my question. In the amendment, as Representative Knirk has identified, there's the phrase, the clinical methodologies and efficacy of research accepted, to me, there's two parts to that. One is the content of that conversation, specifically the audio, and also the efficacy. Trying to separate these out, Medicare, Medicaid, and oftentimes third-party insurances do chart reviews. Is there any place here to be sure that, in fact, the appropriate kinds of audio only interactions are appropriate to have those reviewed in some way?
Thank you, Dr. Woods, Representative Woods. I am not somebody who spends my day-to-day in the bill review, chart review part of the healthcare system. I believe that those systems are in place where charts can get reviewed, clinical efficacy of various practices can be reviewed, and reimbursement decisions can be made in that way. I invented the phrase in accordance with good clinical methodologies supported by clinical efficacy research or accepted clinical practice to basically get the state of New Hampshire out of price setting and to allow other experts to use their regular procedures for determining what emerging standards of care should be reimbursable. There are new reimbursable decisions being made every year. And so I just think this would be added to the pile of decisions that would need to be made. If you have a better term, either you or Representative Knurk, I'm not wed to the term. I was intending to communicate that there are practices that occur in the insurance industry that should be used for this as well.
Thank you. Yeah, I'm going to suggest that we just take the committee people with hands up at the present time and then move on. I'd like to call on somebody from the insurance department who might be able to answer this better. But we have Representative Kofalt in the queue and then Representative Shapiro. So Representative Kofalt.
Thank you, Mr. Chairman. So Representative Edwards, I think the timing of this was a key concern, and I understand that's being addressed by amendment. So, or that can be addressed by amendment. So I think that's a move in the right direction. I guess, on its face, I think a lot of people are reading this and they're seeing this as a sort of a question of paying for someone's time differently if it's remote versus if it is in person. You stated that the cost structure is fundamentally different for telehealth. I think there is over the longer term, there may be telemedicine alternatives that do create efficiencies and have a fundamentally different cost structure. But I think for most people, this is seen as a question of time spent working remotely versus time spent in the room physically with a patient. So I guess I'm trying to understand how you see this as how you see the cost structure as being fundamentally different. Because again, I think the main concern is a lot of people just feeling like this is really about the time they're spending with their patients one way versus another way. The telemedicine alternative being something that is very important, not only during the pandemic, but for some patients who have difficulty getting out and about, can also be convenient to them. So can you elaborate on some of the sort of the longer term implications around telemedicine and how you think the cost structure could change going forward?
Well, let's look at what has happened into the field of mammography. Mammography used to require a radiologist who would spend a great deal of time looking for very, very small microcalcifications that unless you were really trained and really experienced, would be very difficult in many cases to see. So one of the things that has happened because the digitization of mammography, the technology introduction, is that we now have computer-aided diagnosis, which doesn't do the job for the radiologist, but it uses artificial intelligence to take a look at those the patterns and to highlight for the radiologist some areas of concern that can be checked off, almost like a little checklist. And so the effectiveness of the mammographist and the time involved have changed as a result of the introduction of technology. At its core, it's the same. You have a person reading an image, but the technology has fundamentally changed how much time gets spent and the quality of how it gets spent. So in the future with telemedicine, we're going to be able to take all of these biotech feeds that come from our wearables, particularly if we have chronic conditions, and those will be monitored by an artificial intelligence system that can determine whether we're in standard or not and to send us to inpatient care or in-person care or not, depending on those metrics. The way that person engages in the healthcare system is going to be fundamentally different. It'll raise questions of when that artificial intelligence software kicks in and says, hey, you need to go see somebody now. Is that a clinical visit? Is that a billable clinical visit? Under the EO, I think you could argue that it is. But to answer your question, Representative Goldfoot, is that I think we can see these examples of where technology insertions actually does change the quality, access, and cost parameters of how healthcare gets provided. And our clinical systems will continue to be re-engineered to take advantage of it. For example, nobody did telemedicine, or few people did telemedicine 20 years ago. Now we're debating, how much we should pay for it. In 20 years, we're going to be debating, something totally different about technology and whether or not it's killing our local communities because people in Montana are doing telemedicine services for our patients in Laconia. So everything's going to shift because of technology. So I talk a lot. I hope I addressed your question.
Yes, I'm not sure if this is a follow-up or just an observation, that the definition under
You may
this-
follow up or observe. Go ahead.
Okay, thank you, Mr. Chairman. So the observation is that telemedicine, many of the sections under the original bill specify persons licensed by the board shall be permitted to provide services through the use of telemedicine. So I suspect that might preclude some of the artificial intelligence technology you're discussing, but I'll leave it at that.
Thank you.
As a footnote, I just emailed you Amendment 205H, which corrected the missing 180 days. So I'm sorry for the chaotic nature of the amendments, but you should have one in your inbox that does what I intended it to do.
Thank you, Representative Edwards. I would like to call on DJ Betancourt and/or Chris Nikopoulos from the Insurance Department. If either or both of those are still in the meeting, could they be brought up, please?
Good morning, Mr. Chairman. This is DJ Betancourt. Is my volume okay?
Your volume is wonderful. Welcome.
Very good, sir. Thank you very much. Good morning, Mr. Chairman and members of the committee. For the record, my name is DJ Betancourt, and I have the pleasure of serving as the Deputy Commissioner of the New Hampshire Insurance Department. I've been on the job for about 2 weeks now, and I'm getting my feet wet. And so this is my testimonial debut in this new role. So take it easy on me if you would.
Sure. Yeah, right.
As has been the longstanding policy of the insurance department, I am here this morning not to take a position on this particular piece of legislation, but rather to share some thoughts with you for your consideration. As you know, 2020 was a big and significant year for telemedicine, including legislative changes that included a number of insurance requirements associated with telemedicine coverage and payment. It's important to appreciate that given how rapidly the landscape has expanded for telemedicine, it is really too early to fully understand the totality of what those impacts will be as it pertains to the health insurance market. As an example, telemedicine has obviously been an important tool during the COVID-19 pandemic to minimize as best as possible, of course, under the circumstances, disruption to patient care, and has allowed patients to continue having access to their healthcare providers. What is less clear, however, going forward is what the continued demand for telehealth services will be as the pandemic subsides. For some, this new innovation will be their preferred method of accessing care, but for others, they will be eager to return to the familiarity of a clinical setting. But the degree to which individuals fall into one bucket or the other is going to be important for everyone to monitor. Following these issues closely is going to be, I think, an important task for the Commission to Study Telehealth Services that was created last year to really carefully look at. One thing that this committee and others is going to want to monitor is the potential for unexpected pressure on health insurance premiums. And there are some specific questions I think that are going to be important to bear in mind. The first is, will the most expensive in-person providers be the ones to expand their telemedicine services the most? The second will be, will competition among healthcare providers decline because carriers can't negotiate telemedicine rates separately from in-person rates? And finally, will the preferred telemedicine providers be out of state without an in-person equivalent rate? Again, the answers to those questions, I don't believe, can be fully answered because we lack the benefit of long-term data trends and a non-COVID pandemic experience. However, the policy choices in reaction to them are for you, the legislature, to decide. Coverage for audio-only services is a significant policy development, and monitoring how that plays out, I think, is going to be an important course of action. My final comment here on behalf of Tyler Brannon, who is par excellence in the insurance department when it comes to health insurance, is that the provision that the new provision that removes some potentially confusing language as it pertains to in-person is a positive change from an enforcement perspective. But on that point, I also want to be clear, we are only commenting on that to the extent that the previous language had raised some questions and confusion. And I appreciate the fact that Representative Edwards has attempted to clarify some of that. So my comment should not be seen as an opinion on the value or drawbacks of the reimbursement parity policy decision, but just that we do appreciate the fact that there was an attempt to clean up some confusing language. So with that said, Mr. Chairman, I will do my absolute best to answer questions. And if I don't have the answer for you today, I will certainly get it for you in very short order.
Well, all I can say is I wish I was that good 2 weeks into any job I've ever started. Thank you so much. Representative Shapiro.
Yes, thank you, Mr. Chairman, and thank you, Mr. Betancourt, for taking my question. You said that your department was neutral on this bill, and yet you spoke about the Commission on Telemedicine, which was part of House Bill 1623, which was tasked with researching the use of telemedicine and making recommendations for the future. I don't want to read too much into what you said, but do you think it's wise that changes in the telemedicine provisions come out of that commission?
Well, thank you, Representative, for the question. I think the ultimate determination of who should make the decisions on policy is one that you and the members of that commission should decide. What I am very firm on is that it is not the role of the insurance department. Our role is to enforce the insurance rules and regulations that are on the books. Those rules and regulations come as a result of the deliberation of the legislature and other legislative commissions and committees and boards, and that is what we will always continue to do.
Thank you.
Representative Weber.
Thank you, Mr. Chairman, and thank you, Mr. Betancourt, for taking my question. Is it not a significant possibility, if we adopt the language in the proposed amendment, that without the requirement for parity, insurance companies who have a great deal more bargaining power than any individual practitioner will, particularly in the area of mental health practice, seize the opportunity to lower rates, which we already know are woefully inadequate, to ensure that practitioners get even less reimbursement for their services than they are now getting?
Thank you for the question, Representative. A possibility, yes. But what my testimony, I think, speaks to is that the extent to which that would be the case, I think, is still somewhat unknown. again, because you have had a very rapid expansion of telehealth in a very short period of time. You don't quite have the data of those long-term trends to tell you the degree to which that would be the case.
Thank you.
Representative Merchant.
Thank you, Mr. Chairman. Director Betancourt, when I look at the healthcare market today, it's relatively fragmented in the payer. So help me understand what part of the healthcare market this is actually applying to. Because I look at Medicare, Medicaid, under ERISA, you got self-funded plans, you've got commercial plans. So what part of this market are we actually talking about? How large is it compared to the overall market?
Well, thank you for the question, Representative. I think certainly you're looking at the individual market. Certainly you're looking potentially at the large and small group markets.
If I may, Mr. Chairman.
You may.
So basically the market that's left that this applies to is the most vulnerable market we have in the marketplace, because to Representative Weber's point of view, these are people that don't have the bargaining power to actually stand up to the insurance industry to negotiate on their own. So my concern is that we're basically leaving these people here without some sort of defense upon how they can receive the care in an appropriate manner, but also economically provide some sort of reimbursement to the provider to do it.
Appreciate the concern, Representative, and again, how you'd like to proceed in addressing that issue is entirely in the purview of this committee and the legislature.
Thank you, sir.
Representative Betancourt, one of the options, as you know, that we have is to retain a bill and work on it over the summer. And it sounds to me like you're looking for a more longitudinal set of data. Let's go out 3 or 4 months more and see what we've got. Not asking you to make a recommendation, but just your own common sense, now 2 weeks on the job. Would waiting longer to look at additional data seem to run parallel with what you've been telling us?
Thank you, Mr. Chairman. My longstanding philosophy has always been that more information and more data generally gets you to a better end result. But whether or not you'd like to go that direction, of course, is entirely up to you.
Thank you very much. And may you be blessed as you head into your 3rd week of employment.
Thank you, Mr. Chairman.
Representative Marsh. Representative William Marsh.
Hello, can people hear me?
We can.
Very good. I'm trying to participate by cell phone as my internet has gone down. And thank you, Mr. Chairman, for taking my question. And thank you, DJ, for participating with our hearing today. It's a pleasure to meet with you under other circumstances. My question has to do with the federal 1135 waiver, which temporarily allows audio-only telehealth during the COVID-19 pandemic. And as we all sincerely hope, someday the COVID-19 pandemic is going to come to an end. Is it going to create a problem that we have actually put audio-only telehealth into statute here if it is no longer allowed under federal law with the waiver that CMS put forward?
I'm sorry, Representative Marsh, I missed the question.
Right. Under federal law, we are allowed to do audio-only telehealth because of an 1135 waiver that was issued pursuant to 42 U.S.C. 320B 5B. Because previously that was not allowed to be reimbursed by the Center for Medicaid and Medicare Services. Are we going to have a problem that we have put audio-only services into New Hampshire statute as being reimbursable if it ceases to be allowed under federal law by this temporary waiver that was only put in place for the COVID-19 pandemic?
Thank you, Representative, for repeating your question. I don't know for certain. That, of course, is potentially a problem, but that's something that I'm going to have to take back to my department and get some further information for you at a later time.
Thank you. And Mr. Chairman, may I have a follow-up?
You may.
Yes, and would you agree that the research for that might take some time, which of course is a good reason for us to retain this bill so that we can work on whatever issues you raise and have a vehicle to deal with them.
Thank you, Representative. Some of you are trying to drag me into the opinion department here as to what you should do with this bill, and I'm not going to do it. What I
Not that kind of guy.
No, but what I pledge to do is to get as much information for this committee as quickly as I can. That's my commitment.
I thank you. It was a rhetorical question.
Have you ever thought, Mr. Betancourt, of a career in politics?
I tried it once or twice.
Thank you. Representative Weber, do you have your hand up for another question?
My apologies. No, that was just inattention on my part.
That is fine. Well, seeing that there's no more questions from the committee for Mr. Betancourt, we do have a few people from the public who would wish to speak. And just a reminder that the bill so many people reacted to up until last night, there is now a significant amendment in place. So please testify to that and not to what you may have read last night. And with that, I see on my screen a Representative Melbourne. Is it Moran or Moran? In either case, you're invited to speak.
Hi, thank you, Mr. Chairman. It's Representative Melbourne Moran. I'm also a licensed independent clinical social worker. I represent Nashua Ward 7, Hillsborough District 34. I'm really speaking to you today. I'm a small business owner. I own a psychotherapy practice here in Nashua. I also have another site in Massachusetts. I briefly got the overview of the amendments, and even as the amendment is written, I believe that this is a small business crusher. We cannot compete with our larger hospital systems and contracting and negotiations. And I understand that we don't want to do price fixing as government, but in this case, we here, especially for me in my practice, we intend as a for-profit business to compete with the larger mental health centers and other larger facilities in the state. And if that's undercut here by the state by passing such legislation, we won't be able to compete and grow and expand. We're not a group of practitioners who are just academic and part-time, take on a client or two to make ourselves feel good. We're actually trying to do the best we can for our community by treating and using as many resources as we can to reach as many people as we can. For example, with telehealth expansion, I've had to buy an EMR that supports HIPAA compliant telehealth services. But with that, I'm able to see clients that are in the Lakes region while I'm in my office in Nashua. We've been able to expand access to rural folks in our state that may have not been able to access that from their local mental health centers who have tremendous wait lists. We also take AmeriHealth and New Hampshire Healthy Families already compared to the private insurance companies that we contract with, who are not only just reimbursing at a full rate, they're also paying for the copays of the private clients that come through. If we pass a bill that is being proposed, even as amended, I for sure see Medicaid contractors reducing our telehealth benefit reimbursement rate. With that said, I do think, again, we have to consider the self-employed and the small businesses here that don't have such great bargaining power as the larger hospitals. Thank you for your time, Mr. Chairman and many members.
Would you take questions, Representative?
Sure.
Having said that, I don't see a hand up.
That's great because my daughter wants her computer back.
Well, thank your daughter for that. We'll move on. Thank you, Representative.
Thank you.
Next up, I have Dr. Kristen Johnson.
Hi, this is Dr. Kristen Johnson.
Hi, Doctor.
Thanks so much for allowing me to participate today, and good morning from snowy southern New Hampshire. My name is Dr. Kristen Johnson. I'm speaking as a resident of Newfields and as a practicing board certified pediatrician from Exeter. I've spoken to this committee in the past and see some familiar faces on specifically about telemedicine, most recently in the last year or two on expanding the definition of originating sites to include schools. Over the past year, the COVID-19 pandemic has certainly pushed telemedicine, as we've heard, into the mainstream as healthcare was forced to use creativity to balance the healthcare needs of our community with the stressors of reducing close contact as a transmission risk factor. For some families with high-risk health conditions, this risk reduction has continued in dramatic fashion. In addition, we've seen changes to the daily routines for adults and children. Students are doing in-person, hybrid, and remote learning, and we just heard from our representative that his daughter's stealing his computer back. Parents are working remotely, as all of you are here today, but also many are returning to their in-person jobs. This balance has been very difficult for families, including mine, and adding in healthcare has been a real challenge. This is true for both routine, well, and chronic care, as well as more urgent and emerging issues. In our practice in pediatrics in Exeter with CORE, we've worked to find a balance of keeping our patients in quarantine, yet not having them miss out on their medical care. Telemedicine has been a critical part of this. We've had students learning from home and parents back at work in person. A three-way telemedicine visit has provided access to care for that student. And the parents can participate from work as well, and really allowing everybody in that family to participate in that healthcare. Children with potentially having COVID symptoms can be seen from home if they're otherwise feeling okay. And we're offering testing without them even having to leave their car. That limits the contact with others in our office, as well as adding convenience for our patients and parents. Maintaining a healthy staff, as I'm sure you guys are all very aware, has been one of the challenges in keeping our healthcare system open. And this format has really helped to stabilize the health of our workforce. Examples of these visits from my practice just yesterday included a family reviewing their child's anxiety and ADHD medication management from home, since there's an infant in their family with congenital heart disease and they're trying to limit their exposures. A teen with depression who was able to talk to me from their bedroom in a comfortable setting, talking about some pretty difficult topics for them. And a child who met with me from home while the parent was at work. The video was used for the child. Mom couldn't get her video to work. It was only available by audio. And I realized we've taken some of that component out. But again, just as an example of a few things that have required telemedicine just in the last 24 hours for me. This pandemic has brought many awful things, but what we have learned about telemedicine is one of the bright spots in our learning. Today in the snowstorm, we'll have less disruption to the care of our patients as we can keep them off our slippery roads, yet allow them to keep their planned care. While telemedicine, as we've heard, is certainly not appropriate for all situations, it has allowed us to be more agile during this pandemic and to extrapolate that to other situations: snowstorms, kids and parents in separate locations, poor access to transportation, etc. Payment for telemedicine has been an ongoing challenge until this pandemic accelerated the payment equity in the setting of the state emergency. And the advantage of access to telemedicine are clear in the correct setting and with equal payment being critical to supporting ongoing access. I oppose House Bill 602 changing the payments for these visits. They should continue to follow the now standard billing for medical care. We haven't spoken much to it, but the new 2021 billing structure has really changed our day-to-day billing and really focuses on the time spent with patients, on their coordinated care, on the time for documentation, and the other work that we do to care for our patients. And this format really supports the equal payment for time with less focus on the components of physical exam and physical presence, certainly supporting that care is care and that the location of our patient and our provider are not as critical in our new understanding of our federal healthcare payment system. Previous legislation passed by you guys here in New Hampshire requiring Medicaid and Medicare to pay for telemedicine. It wasn't paid for at all before this. We never were reimbursed. And typically what we see is that our private insurances follow the lead of the state Medicaid and Medicare populations and what you choose to do to support that. My opposition of this bill is both in its initial and modified form so that we can maintain moving forward with adequate payment for the advantageous progress that we're making, regardless of our location of services. Thank you for your time, and I'll submit a formal copy of that by email, and I'm happy to answer questions if I can be helpful.
Any questions for Dr. Johnson? Thank you, Dr. Johnson. The chair now recognizes Senator Khan.
Good morning, Mr. Chairman. It's good to see you all. I know you've had a long morning already, and let me be brief. I am proud that I worked with Senator Bradley, Representative Marsh, and Senator Sherman in the legislation for House Bill 1623 in the last session, which established the telehealth parity, as well as provided for services to be provided by multiple licensed practitioners in the state of New Hampshire. The parties who agreed to that legislation were the Department of HHS and the Medicaid Services, the Department of Insurance, health insurance plan providers, the Hospital Association, Behavioral Health Association, the Medical Society. So you can see we not only had bipartisan support, we had broad support from state agencies, the insurance markets, and providers. I want to say I've worked with Representative Edwards on a number of bills. We've had good colleague relationships, and unfortunately, when it comes to this bill, I'm speaking today in opposition to this bill. Look forward to working with Representative Edwards in the future on things in which we have mutual interests. But on this, I think this is a very poorly timed bill. One of the things that was created in the House Bill 1623 passage last year was the creation of a commission to study telehealth services. I serve on that as the chairperson, and serving on that commission, the 14-member commission with me are Representative Dr. Woods and Representative Dr. Marsh. They both have a great deal to contribute, along with the other 11 members of the commission who represent all of the groups that I said had come together. You heard from DJ Betancourt. The Department of Insurance has been engaged through Tyler Brannon, who's working with the study committee. We're scratching the surface. Let me also add that the study commission, in its enabling legislation, has 2 reporting dates. The first is for December 1st of 2022. The second is December 1st of 2024, at which time the commission would sunset. The idea that the parties who came together to write 1623 was that we need to get past this pandemic and see what the adoption rate post-pandemic actually is for the uses of telemedicine, telehealth, and establish some baseline data. We started to scratch the surface on data. It's the Medicaid information that we receive allows us to look at private insurers in the claims database, and what we can observe is that information lags. In order to get good breakdowns on the uses and reimbursements by category of use takes as much as 6 months to have that be in a reportable format. The point being, our December 22nd report is probably going to reflect on usage up until the summer of 2022, which isn't a long way off. Hopefully we have a year's worth of non-COVID related experience that we can compare to the pandemic crisis use. But that we'll see that down the road. We know that the adoption rates in healthcare delivery, it's slow. I come out of the higher education business. They compete neck and neck for change in their practices. Parity is an important part to encourage this market to evolve. The study commission's role is to look at, to solicit information from healthcare providers on their use, from commercial payers, from Medicaid, and from users, patient data to see how well it's worked for patients and to determine if there are cost structures that perhaps are different for types of services that might be offered under telehealth. But we don't have that evidence today. And I guess if there's any overused term in today's pandemic healthcare environment, it is, let's do this on an evidence-based manner and let that evolve. And please use the study commission as a means of reporting as it is intended to the chairs of this committee and in the Senate, Health and Human Services Committee, to the governor, and let us use this commission as it was written to be a means for consolidating evidence-based practice and cost evidence to bring forward to the legislature at an appropriate time when we've got sufficient information to do so.
Thank you, Senator Khan. I was really hoping you would sign in on this because of your work on that commission.
I thought I had.
Okay, well, I'm glad you did. I didn't see it until about 10 minutes ago, but thank you. And I do have one question for you.
Yes.
If we were to retain the bill, we would be working on it in September and October. If we ITL'd the bill, something would come back, put into the hopper, we'd look at it next January or February. In your personal opinion, in terms of the lag of knowing the data, would our working on it in September, October be sufficiently far out for us to come up with some really good conclusions, or would those good conclusions better wait a year?
I think your latter point, Mr. Chairman, is more accurate. I think you'll still be looking at pandemic months data. You won't be able to bring the data current to your considerations in the fall.
Thank you. And with that, I am going to recess the hearing on this, and I will be taking it up sometime as late as I possibly can. And therefore, anyone who then wishes to call to us, please read amendments that have come forward and may come forward in the future. Thank you so much. This particular hearing on House Bill 602 now is recessed, and I will give us 5 minutes for a break.
Are you in the bathroom?
How you doing, big guy?
Mute, Ken, mute.
Ken and Jeff, mute.
Oh, boy, head to mute. Ah, okay.
You're still not muted, Jeff.
Save your work.
Jeff.
Are you there?
Jeff.
We need to save your work. I'm going to make a motion for retention.
Jeff and Ken,
and
you're
for
not
further
muted.
study.
And Ken, you did look-
Jeff, you're not
you
muted.
did look muted. Ken, you did look muted, and then you touched it and it unmuted you. Want to try again?
Hello, this is Representative Marsh. Can anybody confirm that we're still connected? I'm worried that I lost my cell phone and I have to introduce the next bill.
I can hear you.
I can hear you.
I can hear you.
We can all
Thank
hear
you, guys. This is stressing me out that I lost my internet in the middle of the hearing.
We
Yeah.
need to get better internet up north.
It's another argument for audio only.
I have a bill. I have a bill in about that.
Yeah,
Good.
exactly.
I'm in support of that.
We need audio only telehealth because of situations like this.
You got
it. Can't discuss that out of.
Can't discuss a bill. But yeah, Bill, it's due to the wind. Did that take you down?
I don't know. I would have to plow out my driveway and then drive down the road and see. But
Yeah,
since
who
it's
knows?
both the telephone and the internet, I know it's the cable. And fortunately,
Yeah.
the electricity hasn't gone out. So, but this does seem to happen on a regular basis. So we deal with it. It's life in New Hampshire.
The snow is really heavy on the wires and the trees here in Salem.
Yeah, it's lighter up here.
You're somewhat north of my district, Representative Marsh. If I remember, I represent Metro Boston.
Yeah, New Hampshire is north of your district, as I recall.
All right, where is my gavel? Here it is. Aha, okay. Nice oak desk and a nice maple gavel. Whoa. We're opening a hearing on House Bill 163 relative to cannabis use during pregnancy. And we are going to give him, although he's using the phone, the same courtesy as if it was testifying or in person. It will be the same courtesy. Representative Marsh.
Well, thank you, Mr. Chairman, and thank you. This is a novel concept, introducing a bill over telephone. But for the record, I'm Representative William Marsh. You all know me on the committee. I represent Carroll County 8, 7 towns in Southern Carroll County. And I'm pleased today to introduce to you House Bill 163 relative to cannabis use during pregnancy. This bill was inspired by an article published in JAMA June 18, 2019, entitled Association Between Self-Reported Prenatal Cannabis Use and Maternal, Perinatal, and Neonatal Outcomes. Briefly, a cohort study of over 660,000 pregnancies in Ontario, Canada, found the rate of preterm birth among reported cannabis users was 12% versus 6% in non-users, a statistically significant difference. Clearly, that's neither good for the babies nor the health insurers. This confirmed a previously reported study from Colorado in the Journal of Pediatrics in 2018. Meanwhile, a June 2018 study in obstetrics gynecology reported that a survey of 400 cannabis dispensaries in Colorado found 69% of them recommending cannabis for first trimester morning sickness. My survey of available medical literature about this was made much simpler by our Surgeon General, Jerome Adams, who issued an advisory on marijuana in the developing brain in August 29, 2019. In addition to the concern about preterm births, Dr. Adams is rightly concerned about subsequent learning disabilities. For details, interested committee members should visit www.hhs.gov and look at the report. If and when I get my computer back, I'll be glad to email you a link to the report. After I filed this bill last year, Abby Rogers from DHHS contacted me and asked me to expand its scope slightly to include cannabis use while lactating and the risk of accidental poisoning, and I redrafted the bill with their language. I similarly did so this year after filing the bill. There are two differences between this bill and last year's bill. House Bill 1591 last year passed this committee 18-0 and was adopted on consent, but died a COVID death in the Senate. We added language about cannabis use during adolescence to reflect the Surgeon General's concern, and we asked the department to document through rules that counseling had happened. That could be as simple as a checkbox on the certification form. The entire effect of this bill is to require conspicuous warnings be posted and information be made available, mirroring that's currently being made available in Colorado. Work is already being done on educational materials, which I believe Representative Knurk intends to share. I thank you, and I'll be glad to take questions.
Any questions for Representative Marsh? Representative Acton.
All right. Thank you, Mr. Chair. And good morning, Representative Marsh. Thank you for taking my question. This is obviously no brainer. The question I have is, are we getting into the situation where we're going to just be adding bits of health information here and there, where we should maybe take a step back and create a process of communicating from the HHS to the individual patients? Now, they do send out letters and so forth, but they don't have email lists and so forth. That's all seen as security issues of not wanting to be exposed as taking part in the program. But I just wonder if are we going to keep encountering these medical bulletins, and so putting them into the law one by one seems self-defeating, where we could create a system where that handles a little bit differently. Thank you.
Thank you, Representative. I'm glad for your question. I would like things like this to happen automatically, but as we know, things happen when the wheel squeaks. And we were told last year that the department had been meaning to get around to doing this for about 5 years and hadn't quite done it. I think you and I both recognize that at some point in time, it is highly likely that our state will join the states around us and make cannabis more widely available to the public. And I will admit that one of my intentions here was to have the department develop materials so that when that day comes, they could more widely distribute their materials. But that would be a different bill for a different day. This bill is just to require the materials to be developed for the dispensaries.
Representative Gay.
Thank you, Mr. Chairman, and thank you, Representative, for taking my question. How many ways do we have to notify the public? I mean, it is a no-brainer, but it's a no-brainer to us. And unfortunately, in our culture, there are lots of people who just don't want to think there's anything negative about using cannabis. So we've already discussed a bill about using cannabis for medical purposes, which I'm guessing doesn't apply to being pregnant. So, this to me seems like a really basic way to say that it's extremely dangerous. And if we're going to talk about marijuana at all, this ought to be part of it. And it is, in my book, it is affected tremendously by the law. So how many other ways can we tell people? This just seems like one really critical way.
Thank you, Representative, for your question. I do believe that the department intends to testify on this bill. They did on our bill last year, and I believe that they can answer that question far better than I can. So I will let them do so.
Representative Merchant.
Thank you, Mr. Chairman, and also thank you, Representative, for taking my question. I commend this bill. I think it's a step in the right direction. I would actually go a step farther if we could. When I look at other things available to us in the marketplace to protect the unborn, we put labels on nicotine, we put labels onto alcohol, particularly alcohol. I think this is a step as far as informing the person in the dispensary. Was there any thought put into adding a label onto the product itself once it leaves the dispensary versus just being inside of the dispensaries?
Thank you, Representative, for your question. I think the issue of labeling of product is an important question. And in fact, I happen to know that there's a bill before the Commerce Committee to that effect, but that's not the bill that we're discussing here today. And it never crossed my mind to put labels on it when I wrote this bill. But I agree with you that it's a very reasonable idea. And I would suggest you address your comments to the Commerce Committee.
All right, thank you.
Representative Jerry Knirk is a co-sponsor and has done a lot of work on this subject, and I would like to invite him to testify on this bill.
Thank you, Mr. Chair. Everybody hear me okay?
Yep.
Okay. Yes, for the record, I'm Representative Jerry Knirk and representing Carroll 3, but I also serve as the chair of the Therapeutic Cannabis Medical Oversight Board. This is the board that is tasked with looking over the medical issues involved in the therapeutic cannabis program. We heard about the other board that we have already voted to get rid of, and because that had to do with just kind of the function and getting it up and running. This is an ongoing board to look at medical questions. So we have actually been dealing with this for over a year now. First, I have to point out that one important thing is that the Surgeon General's report had to do with cannabis in general, not just therapeutic cannabis. He was talking about recreational and therapeutic. And the great majority of users who are pregnant or adolescents are actually recreational users. The data regarding cannabis risks that we have so far to use to make decisions actually comes from the recreational users, as the therapeutic cannabis literature is just emerging. Now, the risks in therapeutic use may be different than in recreational use due to the different patterns and the different dosage. Having said that, we still share the concerns. So it's important to understand that the goal of using cannabis in the therapeutic setting is different from the goal in recreational use. It's not used to get high, but instead to treat a condition. The doses of therapeutic cannabis are titrated using a rubric that we call low and slow. You start with a low dose and you slowly build to achieve the therapeutic effect while minimizing the side effect of euphoria. It is important to understand that the peak ages for certified patients in the therapeutic cannabis program in New Hampshire is in the 50s and the 60s. That's the age group. For a 2021 Senate bill, we just interrogated the database regarding the number of certified patients less than age 21. 25 is in this bill, but 21 was in the other, and that's how we interrogate it. Out of 10,688 total qualifying patients in the therapeutic cannabis program in New Hampshire, there are only 10 minors under age 18 and 66 patients between 18 and 20. So it is actually also a fairly small group. That doesn't take away the importance. The TCMOB has not had the chance to review this particular view. It's on our agenda for tomorrow. We did review the 2020 version of the bill, HB 1591, which addressed pregnancy and lactation, but did not include this section in adolescents. And we voted to support the bill 9-1 with an initial recommendation to add a requirement for counseling by both the ATC and the certifying provider for all women of childbearing age about the risk of cannabis during pregnancy and lactation. The next month, though, we revisited our thoughts on this, and we then expressed concerns with each other about the ATC staff, remember ATCs are the dispensaries, about the staff qualifications to provide such counseling, and also difficulties with gender determination and profiling of women of childbearing age. We realized that asking the ATC to provide the counseling about risk of cannabis in women in childbearing age would actually hold therapeutic cannabis perhaps to a higher standard than we do with other drugs in the pharmacy. So we felt that actually we would not support the counseling in the ATC, but we felt the counseling did belong in the certifying provider's office. So one of the main goals for the board in 2020 was to develop educational materials. We have already developed educational sheets regarding the risks of cannabis use during pregnancy and lactation, both for providers and for patients. And we're ready to proceed with the implementation of these educational initiatives. Now, I sent to you, when I sent this testimony to you a couple of days ago, I included those information sheets. Again, we have approved the content. That's the kind of content we expect would be used in some of the informational and educational work we work on. Representative Marsh included a requirement for counseling in the new bill, placing the burden of counseling on the certifying provider, which is where we feel it should be. We have not reviewed this particular language, but given that we've already agreed with the counseling being done by the certifying provider, I'm pretty sure they'll be happy with this. The new bill also has a requirement for warnings of the risk of cannabis in adolescents. Though we have not had a chance to discuss that particular requirement in the context of the language of this bill, we have discussed and recognized the risks of cannabis use in adolescents, and we have already developed educational slides for providers regarding these risks. And that educational slide deck was also attached to the email I sent you a couple of days ago. You also may note, late last night I sent an email that had PDFs of some of these, of the more detailed educational decks, and those included some posters and other types of educational materials used in some other states. That gives you an idea what Representative Marsh should be talking about with this bill that he's discussing. So I would expect that TCMOB will probably support this new section of the bill and will develop the educational materials for the risks of cannabis use in adolescents. Now, a couple of things that I did have some questions about. The counseling requirement on page 2, line 7 probably needs to be amended. So on the bill, page 2, line 7, because it talks about counseling for women of childbearing age and adolescents 25 years or less. We would need to say counseling for patients less than age 18 needs to include the parent or the guardian, just for the usual issues we do in medical care. The patient should be counseled, but in this case, probably a parent and guardian as well. I also, though, question whether the specific risks should be prescribed in statute. This is done if we look at page 2, lines 13 to 14, and lines 22 to 25. That identifies which risks need to be enumerated. But we do know that medical knowledge evolves over time. Perhaps the decision of the risks to be included should be made by the TCMOB. I would say, though, that our lists are almost identical, so we have no difficulty with that. Sorry, I cannot say we here. We have not looked at the new language. I do not, and I do not expect that board would have difficulty with the language of the risks that are used. But the question is, do we want it scalable for the future by keeping out some of those details that might change over time with changing medical knowledge? Regarding Representative Gay's question, we are working to disseminate this information to providers and to the patients. For the patients, a handout, also a poster. We would agree with that concept that's in this bill. And also, again, because of the counseling required, we would be very happy if the certifying provider did also review these issues. So I am quite sure that we will agree with this bill since we agreed with last year's 9-1, but we have not had a time to go over the exact language. That's tomorrow. Thank you.
Thank you, Representative Knurk. And before I recognize anyone to ask you questions, I see that Representative Casey Conley is on the call. And Representative Conley, it is my intent to move right into your bill after this one, and I hope it won't be very long. So hang in there, brother. The chair recognizes Representative Woods.
Thank you, Mr. Chair, and thank you, Representative Marsh, for taking my question. I remember those papers and read them when they came out, but I don't recall the content, the CBD versus THC. And the reason I ask, we know that the CBD part can be quite useful medically, i.e. in the newborn and the very young with seizure disorders. Was that parsed out? And I think it's probably important to know, because we've have bills and we have actually standalone companies now selling just CBDs, and that would be helpful to be able to provide that information. Were those studies address that separation?
To whom are you addressing the question?
To Representative Marsh or Representative Knurk. I just don't recall the paper. They might, and I think it's important to make that we can differentiate.
Do you want me to take that, Representative Marsh?
Well, I would just say, to the best of my recollection, it wasn't addressed, but since I can't look up the paper because my computer's down, I can't really answer it well.
Point of order, Mr. Chairman. I think it would be simpler for all of us trying to follow along at home if only the person who is currently testifying is asked questions, and we don't switch between the person who's currently in the batter's box.
Thank you.
Go further afield.
Thank you. And that would be Representative Knurk.
Okay. Well, I'd be glad to speak to that. Can you hear me? I'm not highlighted. There we are. Okay, now I am. Basically, again, as I said earlier, most of the data we have regarding regarding cannabis risks comes from the recreational field. And the whole point with recreational is most of the time it's really not regulated. Most of the time we don't really know. And most of the studies that we've looked at don't separate those out. We are just finally getting some studies relating to just CBD. You are correct. CBD has very distinct uses and is actually approved as Epidiolex for seizure disorders. But we still do not have enough data to let us know whether or not one strain is released that much safer than the other strain. So it's still, the data is in its infancy, but most of these have to do with recreational use. And as a result, it's usually the standard, which is a fairly high THC content.
Any other questions for Representative Knirk? Seeing none, the chair recognizes Michael Holt from the department.
Hello, this is Michael Holt. Can you hear me?
We can.
Great, thank you very much. My name is Michael Holt. I'm representing the Department of Health and Human Services. I am the administrator of the department's therapeutic cannabis program. The department's not taking a position on this bill, and I would offer that Representative Knirk stole much of my testimonial thunder. His points were exactly going to be my points. So I won't reiterate except too much, except to say that much of what this bill is mandating is already being done, either required by statute, administrative rule, or practice. Some of the differences are this information needs to be provided in poster format. And the other main point that I would make is that the department shares the concern of codifying these health risks in statute. Cannabis science is evolving. We don't want to lock ourselves in, and that the TCMOB, the Therapeutic Cannabis Medical Oversight Board, will be taking a review of this bill up at tomorrow's meeting. The department would like to see this list of health risks adolescents either be vetted by the board first or removed from statute entirely, and let the board direct us and the ATCs on what information should be provided to patients via providers and the alternative treatment centers. So that's, I'll close just by highlighting the numbers again. Total patients, 10,688. We've got 10 minors on the program. We have 310 adolescents, so age 18 to 25. So the scope of this the population is relatively small. Women of reproductive age is estimated to be about under 1,500 patients enrolled in the program. So I'm happy to answer any questions from members. Representative Knirk did most of the lifting on this one.
Any questions for Mr. Holt? Representative Acton.
All right. Thank you, Mr. Chair, and thank you, Mr. Holt, for taking my question. I was wondering, can you give me a ballpark figure of how many medical providers there are that have taken part or recommended cannabis to their patients? That's one part of the equation. Now, how many people we got? How many doctors do we have out there taking part?
We collect this data. We have about 1,200 providers who have certified at least one patient. And that's the current number. That's not the number of total providers who may have certified one patient a number of years ago, but no longer have a current patient. So that's about 1,200 providers. Memory says close to 200 of those are out-of-state providers. So about 1,000 in-state providers and about 200 out-of-state providers. Those provider types are physicians, APRNs, and as of a couple of years ago, physician assistants. Those are the provider types who can certify their patients for the program.
All right, thank you very much. That's impressive numbers.
Thank you. The only other hand up, okay, he's put his phone down. Representative Snow, please unmute and ask your question of Mr. Holt.
Chris. Hello, Representative Mr. Holt. I have two questions. Thank you for taking my question. And thank you, Mr. Chairman. I have two questions. You said that the information can only be presented in poster form. In the end of the bill, it says brochures. Does that preclude producing a brochure with the same information?
My testimony was that much of this information that is required by this bill is already being provided by the ATCs in other formats. This bill would require specifically a warning poster to be posted in the dispensary on these two issues. That was the testimony that I provided.
Oh, okay, but that same information will be produced in a brochure that could be distributed elsewhere. Is that not correct or correct?
We currently do have a brochure, if you will, a double-sided color copy that has information about the program that includes warnings about use during pregnancy and while breastfeeding, and also information about safe storage, disposal, and accidental poisoning. This information is already in brochure form. We do not require big posters to be posted in the dispensaries at the time. That's going to be a cost for the department to develop and print, of course. It's not, it's an issue that we'll talk about in the TCMOB meeting tomorrow. But again, the information on adolescents is not being currently provided in any format. So that's a good addition to this bill to focus education efforts on that population.
Thank you very much, Mr. Holt. Seeing no further hands raised, the chair calls Kate Fry from New Futures.
Oh, he did it. Good man.
Members of the committee, my name is Kate Fry from New Futures. It's nice to see you all virtually. As you know, we're a nonpartisan nonprofit organization that educates and advocates to improve the health and wellness of New Hampshire residents. And we are here in support of House Bill 163 relative to cannabis use during pregnancy. As Representative Marsh had stated, there was a JAMA article that showed the proportion of US women using cannabis during pregnancy more than double between 2002 and 2017. And we all know use during pregnancy can be harmful to a baby's health and include many serious problems. We support HB 163 because it would require the ATCs to provide information regarding the risk of cannabis use. So I will agree with Representative Marsh that this has been about a 5-year discussion. New Futures, along with Prevention Partners, created very easy to use educational documents for the therapeutic cannabis program and for the ATCs back in 2016. I think those are still the forms that Mr. Holt referred to. These documents highlight tips for safe and responsible use, child safety, and preventing youth use. And it was a collaborative effort with the ATCs and DHHS and prevention experts. However, it's always been unclear whether they are actually being used by the ATCs. And kind of after 4 or 5 years of these discussions, we are advocating, we do think it makes sense to mandate these efforts. And we would also recommend that these documents are mailed to clients when they receive their therapeutic cannabis ID card. It'd be a relatively easy thing to do. This could be done already. I haven't had a discussion with the department in quite some time about this, but it's just an 8x11 piece of paper that could easily be included with the cannabis identification card. As far as the cost goes, my understanding is the Governor's Commission on Substance Misuse actually set aside $10,000 to cover the costs for this, for the Division of Public Health Services, because it was being said over and over again that the therapeutic cannabis program couldn't cover the cost. So I'm not sure why this would be an additional cost to the public health. A couple of things I just wanted to state too is, again, my testimony is specific to the part of the bill is cannabis use during pregnancy. I absolutely agreed with Representative Gay that it's a no-brainer, but it actually makes sense with prevention efforts. Sometimes you have to say the same message over and over again for folks to hear it. So I think it makes even more sense that this information is right in the fingertips of folks when they receive the ID or when they go into the ATC. And again, we wouldn't advocate that you have to have a big shiny poster. Again, we think you could easily put this information in the card and have these available at the ATCs. And again, because not everybody can walk into an alternative treatment center. You have to have a card. It is unclear whether or not they are. I think mandating it does make sense. I will just touch on, I wasn't going to speak to the part of the bill regarding adolescents use, because honestly, I just realized it was in the bill. But one thing I would mention is I think you do need to be as proactive as possible. I definitely agree that you should defer this to the Clinical Oversight Board, of which Representative Knirk does a good job. But I think we should look at what other states are seeing too, once they have moved to recreational use. I was actually on a call from someone from Colorado, where right now, who we all know had therapeutic cannabis for some years and then moved to recreational. They're seeing a huge jump in the number of 18 to 20-year-olds who have actually left just recreational use and have gone to the medical side of things, mostly under the condition of pain. And those numbers jump from like 300 in the age group of 0 to 17 to 3,000 in the group of 18 to 21. And they move to this category because there are no taxes and because they can get higher percentage THC products. So I just think we need to be proactive. If indeed we move in this direction, let's learn from other states who are seeing this. Even though, as Representative Knirk said, the cannabis, CBD is one thing, THC is another thing, and the two different programs are separate, but these other states are seeing people actually leave kind of the recreational side and move back to medical for reasons that are beneficiary to them, as far as they don't have to pay taxes. So I just wanted to bring that to your attention. And I think that covers it.
Thank you, Ms. Fry. Will you take questions?
Absolutely.
Any questions for Ms. Fry? Representative Snow.
Thank you, Mr. Chairman. I unfortunately got a phone call right when I was, and I want to do a follow-up to my last question, which is, if this bill about allowing increased medical cannabis users to grow cannabis themselves, they would not be going to the dispensaries. Is there any way we can get information to them with the same warning about this that they would get if they walked into the dispensary? And the second thing is that I wondered about is that it's probably too mammoth a job to have anybody really undertake, but it does seem to me the family practitioners and obstetricians should really have this information available to them. So I just wondered if Mr. Holt could answer those questions for me.
Mr. Holt has left the meeting. This question is only addressed to Kate Fry.
Okay.
And she can take the question or not if she wishes.
I will attempt to do my best. I think your first question is if a home grow bill were to pass, and I'm only speaking specifically to this bill that is really pertinent to just the alternative treatment centers who are under the therapeutic cannabis law. Certainly if home grow passes, that's something that should be considered, but obviously that would be much harder to, I think, regulate, whereas the ATCs, it's a lot easier. So I think it's just projection to look at this point whether or not that makes sense. And so I'm just speaking to the part of the bill today that addresses the ATCs. Regarding your question on OBGYN, I think that's a great point. I mean, please keep in mind that they don't prescribe. What they do is certify, what providers do is certify. I have had numerous amount of conversations with OBGYN who are just stunned, how many have asked them about the use of cannabis during pregnancy, and they try to provide as much information as possible around the risks, and that there are other options for medication for things like morning sickness. So, I think they have a genuine concern about how they get this question over and over and over again. And so that's enough for me to think that there needs to be some kind of warning information out there.
Thank you very much. There are no further questions for this testifier. Is Nancy Sheridan from the public still on the call?
She is not.
She is one of my constituents. She was on for 602, which brings up a question. Are you planning to go back to 602 today or some other day?
It will have to be some other day because it will have to be announced.
Fine, thank you.
Is there anyone else who is from the public and who has not testified yet? That being answered, it seems, in the negative, I'm going to ask Representative Marsh, would your pleasure be to move to exec this bill, or in light of Representative Knirk's statements on two different items on page 2, would you like us just to adjourn this hearing and exec it in a couple of weeks after more information has come in?
Well, I believe you could exec it fairly soon because Representative Knirk, if his committee recommends some changes, they sound to me like they would be friendly amendments, and we could just introduce those after his meeting tomorrow. So I would be content to wait for that. I don't think it necessarily has to wait for a couple of days. I don't see any urgency towards our passing this bill, so I don't feel we need to exec it at this time.
Okay, good. Thank you. That was my guess, but I wanted to give that as a courtesy to you. With that, I close the hearing on House Bill 163, and we move to now open the hearing on House Bill 240 relative to identification of cannabis strain for therapeutic cannabis. And the chair recognizes Representative Casey Conley.
Thank you, Mr. Chairman, committee members. I am Casey Conley, State Representative from Dover, here to introduce HB 240. This bill would allow therapeutic cannabis dispensaries to use the name of the specific cannabis strains when dispensing them to clients. These names would be used both inside the dispensaries to identify the cannabis on the packaging that patients would leave with, and on dispensary websites when identifying inventory and so on. What this bill does is fixes an issue in our therapeutic cannabis rules that prohibit strain names from being used like this. Currently, they are represented by initials and shorthand. And while that might seem simple enough, it can get confusing quickly. A quick look at the Temescal Wellness Dispensary in Dover last night showed a healthy assortment of cannabis strains available. These include something called BDR PRJ, GBA PRJ, or even AC PRJ. And if those weren't satisfactory, there's BBK, SD Plus, and SRD. And I don't know about you, but I have no idea what any of that really means. So as I wrote this testimony last night, I had to constantly refer back to that website to make sure each of those were spelled correctly. It was easy to transpose a letter or mistype a letter here and there. And that's the problem, is that, mistaking a letter or two with this medicine would mean you would come home with an entirely different product than you intended. Each of these strains have different effects. They provide different relief for different patients. But under the existing rules, customers have to rely on this awkward shorthand. And we can resolve it by passing this bill and joining near every other state that allows the actual strains names to be used, including Maine and Vermont. So What are these names? This is things like Northern Lights, Pineapple Express. These are the actual names of the strains, and in many cases, they date back 50, 60 years. They're the same name industry-wide. It's not as if it was just sort of the brainchild of a store manager or a dispensary manager somewhere. And these, for cannabis patients, these are just as recognizable as things like Lipitor and Claritin and Prilosec that you could pick up at the pharmacy. So I ask you to please recommend passage of this bill. It's a streamlining of the process. It's a very simple fix. With that, I'm happy to take questions. I'm also happy to defer questions to former Representative Tim Josephson, who plans to testify later and was an original sponsor of this bill, or others who may testify later. But thank you for the opportunity.
Thank you, Representative Conley. The chair calls on Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question, Mr. Conley. I'm not sure exactly what full name actually means. You made reference to a quote standardized commercial name, but that's not something that's required. In medicine, there's an agency through the AMA which has a naming criteria that's used, and that becomes the like Lipitor and other kinds of names. That's not the chemical name. I wasn't sure if you meant a botanical, the full name being the botanical name. Just a full name may not really, it doesn't seem like that would really address the issue in the sense that even though it may be quotes, the supposed standard, there's nothing that says that that same strain could be used under a different name. So it may be the same in Colorado as it is in Temescal here in New Hampshire, but not necessarily required to have the same name. And a follow-up part of that is what happens if the a particular medication is a compound with multiple agents within that, how would that be named?
Representative, thank you. I'm, as I indicated and fully acknowledged, I'm not an expert on this. And rather than do my best to give you correct information, I'm going to defer that question to later testimony.
Chair recognizes Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. I noticed that in your testimony, you said you were concerned about the fact that currently these names are prohibited. And in your bill as it is drafted on line 3, you are now going to require the alternate, the full name of the cannabis strain. Did you want to make that mandatory and use the word shall, or would the word may and leave it to the discretion of the dispensers be a better way of going?
Representative, thank you. I don't feel strongly on this point. I think may might be better than shall, but as you know, this is an issue that hangs up this legislature from time to time. So, but I do believe may is probably preferable.
Thank you. I was just trying to get your thoughts on whether you were wanting to mandate it. So thank you.
Representative Gay.
Thank you, Mr. Chairman, and thank you for taking this question. To me, the real issue is not just the name of the product, but the content. Is there any reason why all I can think of right now, even though there are over 75 compounds already identified in various kinds of marijuana, the ones I'm really concerned about, of course, are the THC and the CBD. Is there any reason why that can't be listed or mandated? Because that's the real issue. Do you really want to get high or you really want to get well?
Representative, thank you. I, at the risk of saying what I said before, I'm going to defer that. The former representative is more versed on this than I, and rather than give the committee incorrect information, I would rather just defer that question.
Thank you very much. And seeing no hands, I said that before I saw a hand. I'm going to now ask Representative Tim Josephson to speak because he's been deferred to on a couple of occasions by the primary sponsor. Representative Josephson.
I do not see Representative Josephson in the list. If you are there, it looks like we have a Helena Josephson. Perhaps he is using a different name. Shall we give that a try?
All right. Helena Josephson.
That is actually me. This is Tim Josephson.
I won't ask.
That's my wife. That's my wife. So I
my suspicion.
switching around devices here. So
got it.
Okay. Thank you very much, Mr. Chair. Thank you, committee, and hello to all my former colleagues there. My name is Tim Josephson, former representative here in the State House, and this was a bill that Representative Conley was kind enough to shepherd through for me this session. For the record, I am a card-carrying caregiver for therapeutic cannabis for 3 people, my wife, my mother-in-law, and one more person who's actually a member of the House. So what this bill seeks to do is to allow the true name, the botanical name of cannabis to be strains to be printed on the labeling of medication at the dispensaries in New Hampshire. If you're not familiar with strain types of cannabis, it's an agricultural product and as such has different lineages. You can think of it similarly to like different varieties of apples. Galas are different from Northern Spy, different from Macintosh, different from Granny Smith, et cetera, et cetera. You know, cannabis strains have a wide variety of difference between them, but the effects are more pronounced than just being sweeter, tartar, or better for your pie, or better for applesauce. One website that may be of great use to you here would be leafly.com. That's leafly.com. It details all of the different strains. And from their website, here's a little description about the differences at a base level. Marijuana strains are organized into 3 primary types: sativa, indica, and hybrid. Each type of strain has unique effects on both the mind and body. For example, sativa strains are uplifting. They pair well, with activities, physically active for patients that need that. On the opposite end of the strain spectrum, indica strains are relaxing and can amplify a deep level of physical sedation, meaning indica is great for those times for deep sleep for when patients need that. Lastly, there are hybrid strains that fall between the indica and sativas. Hybrid strains offer a combination of both energizing and relaxing effects. Perhaps they're great for times when it's too late for an energizing sativa or too early for a sedating indica strain. And so while the New Hampshire rules permit the differentiation between indica, sativa, and hybrid, it effectively stops there. As Representative Conley alluded to, the different letters are all over the map there. You can have a sativa LH, which is different from sativa SC, each doing different things. Perhaps LH is good for appetite, but SC is good for energy. The hybrid category can be more confusing since hybrids lean towards sativa and some lean towards indica. And just having initials can lead to mix-up, as one hybrid might be what you need in the afternoon because it helps your chronic pain without giving you too much energy late in the day, but not enough to make you sleepy. I first became aware of this problem when my mother-in-law got her cannabis card. She has, she has been a cancer survivor, a transplant recipient, all sorts of things. And so she shared with me the labeling system and its confusion of only allowing initials and not names. And so with her getting up there in age and driving being an issue, I became a caregiver for her. While helping her navigate names and strains, it was definitely confusing with the different initials. And I wondered if this is confusing for me, what do you think it's like for elderly and disabled people who need their medication? It is confusing for people, and there's no other way to say it. These folks, like my mother-in-law, they're from a time when cannabis was fully illegal. And by having to use code like this, it gives this legitimate medical product an air of illegitimacy or like shadiness. She feels like she's still having to sneak around to ask me to pick up her medication when it would be much more legitimate and concise for her to say, I need some Northern Lights and I need Point Break, instead of saying like, hey, I need some stuff. Why is this medication being censored? We don't do this with the medications we get in pill form. Can you imagine, go to your, you have a medicine cabinet in your house, go to your medicine cabinet and imagine all your pill bottles being blank. And now your Lipitor is classified as LP, Prozac is PZ, Claritin is CL. And now you have a medicine cabinet full of just initials. Many people take lots of different types of medications daily, and strains of cannabis are no different. I spoke with folks at the dispensaries, and when I asked about the naming system, I was told they're not allowed to put the actual names on containers due to a rule at DHHS. Why would they not be able to say the actual name? I was told it was because of protecting children. And the true labeling of strain names would be too tempting for children. You know, there are strain names like Fruity Pebbles or Bubblegum Kush, but these strains are named from the lineage of plants that go back decades, and they're created each strain. And as such, it's important to be aware of, especially for patients who are seeking to find specific strains to treat specific conditions. If someone needs a strain that helps with appetite, they should be able to tell that strain comes from a lineage that helps that condition. The dispensaries did not just pull these names out of a hat. They're heirloom varieties, and some old names go back decades. This is a long-established system that other states have used just fine. There's no reason to censor ourselves among adults. You know, the information is really, if you look, if any of you are familiar with what the packaging looks like at the ATCs, it's very plain. It's just in text font. You know, it's plain font on a medical package similar to a pill bottle. It's not snazzy packaging. It's not attractive labeling. It's not colorful fonts. Those things, if you're concerned about children, those things are in liquor stores, you know, on things like, you know, a quick look at the schnapps on the state liquor store website reveals names like 99 Bananas, Buttershots Burst, Hot Damn Cinnamon, Luscious Pomegranate Pleasure. You know, if we label our liquor that, we let kids into the liquor store. Why can't we label our medical packaging as a plain font? You know, well, kids are not allowed inside of the ATCs. You just cannot take children in there. Patients are told that you have to secure your medicine, and they do. The therapeutic cannabis program has been in effect for several years now. Any fears that children would be swayed by a plain label on a medication container should be long gone. Dispensaries have been very helpful in producing. They do give you a little strain guide with full names that you can get in person. But what happens if that patient loses that sheet? What happens when the dispensary gets new inventory? Clear labeling on packaging would help. In the initial consultation with the dispensary, patients are told about the requirements to secure their medication, keep it away from children. This is more than when you get a prescription from your doctor. Patients are very aware of the penalties for not taking care of their medication. So in conclusion, I ask the committee, hear the request of people for clarity on their medication. A well-informed patient can make the best decisions for their medical cares, and we should not put up barriers to information. And just a few quick things to refer to Representative Woods. This would not, and Representative Gay's program questions, this is not specifically to the chemical compounds that are in there, but rather the given botanical names, as you alluded to there, Representative Woods. You know, so like I said, Northern Lights, Point Break, things like that. So that's, and I'm happy to take any questions.
Thank you, Representative Josephson. The chair recognizes Representative Folsom.
Well, thank you, Mr. Chair. Thank you for providing your testimony for us today, Mr. Josephson. Very, very informative. I am in support of this bill, but I have a question for you. I'm referring back to the question of Representative Weber. Being a former legislator, do you have a preference between the may and the shall?
I think the shall is important for the packaging. The shall is important to have the packaging be labeled with the actual strain name. The may is on the website so that the dispensaries do have the option to put it on their website or not. I suspect that they would all put it on their website if they were allowed to. Again, I suspect if it was may on the labeling of the package, that the dispensaries would go ahead and label them if they were allowed to choose so. I feel that it should be on there in terms of clarity for patient use.
Thank you. Representative Nelson.
Thank you, Mr. Chairman. Thank you for taking my question. How many other states require this?
Require the names on them?
Correct.
How about, I don't know of any other state that requires an abbreviation like we do. The only other thing I can come up that I have seen is that Connecticut has an alternative naming format, which is actually even more confusing. So I would not recommend that. But every other state that I looked into, I'm not sure about requiring it, but they all allow it. How about that?
Well, how many states did you, follow up, excuse me.
Yes, you may.
Sorry. How many states have you contacted or researched?
Just in my research on looking, I looked at maybe 10 to 15 different states online.
Thank you.
Like looking through their information.
Thank you.
Chair recognizes Representative Woods.
Thank you, Mr. Chair, and thank you, Mr. Josephson, for taking my question. For my ease, can you direct us to the RSA or is it rules relative to the inability to change the labeling. You mentioned
It would
that-
be, yeah, it would be in the rules, DHHS rules.
Okay, thank you.
Representative King.
Yes, thank you, Mr. Chairman, for allowing me to ask this question. And thank you, Mr. Josephson, for taking the question. Can you repeat the website that you had mentioned before? I tried it, but it told me access was denied. So I don't know if it's something that is temperamental.
Yeah, it's leafly.com, leafly.com. I'm not sure, because it is, for adult use and, it's not for kids. It asks you, are you 21 years or older when you log in, I believe, or when you go to it. So it may be blocked by some, but that is the website, leafly.com.
Thank you. That was my misspelling anyway. Thank you.
Okay.
Any further questions for the Representative Emeritus? Is there any member of the public? I show no one on my screen.
My wife is here.
The real Helena Josephson, correct?
You see
are
it?
recognized
Yep.
to speak.
Hello, can you hear me?
Yes, we can.
Okay, thank you. Thank you, members of the committee, for your time and consideration. My name is Helena Josephson, and I'm a resident of Canaan. I'm speaking as a member of the public and a registered patient in the therapeutic cannabis program. The changes proposed in this bill would benefit me as a patient in multiple ways. Along with the medications prescribed by my rheumatologist and other providers, therapeutic cannabis plays an important role in the management of my chronic illness. Armed with a prescription from my rheumatologist, I can go to rxlist.com and learn about side effects and dosing of things like hydroxychloroquine, which I do take, but not so with therapeutic cannabis. I have my doctor's blessings, but I'm on my own to find strains and delivery methods that will help me the most. Fortunately, there's a lot of information available online, and it's only getting better as more states get on board. The website leafly.com catalogs thousands of strains. Like other agricultural products, different varieties of cannabis have different effects. Heritage strains with well-known effects are crossed with others to create new strains. So if I search best strains for nerve pain, I might find out that Blackberry Kush is a patient favorite, but how can I use that information? My dispensary's website doesn't have anything with that name. I might see BK and PK, but what does that tell me? At the dispensary, they could give me a strain key, which is literally a decoder, so I can decode the names of the products on the website and in my medicine cabinet. But that doesn't actually help me when I'm doing research at home. Through trial and error, I've learned which strains ease my worst symptoms. I have complex medical conditions, and some strains don't help me. I'm also learning more about the various medicinal components of cannabis, like the cannabinoids and terpenes. And as we get more detailed information, I can use that to choose better medication when I visit my dispensary. It would be so much more helpful if I could do this research at home online before I go to pick up my curbside order. Thank you, members of the committee, for hearing my testimony. And if anybody has any questions for me, I would be happy to answer or try.
Seeing none, I'm looking for Representative Casey Conley. I do not see him on my list. I hope he hasn't dropped off.
It looks like he has.
He has dropped off. I was going to give him the opportunity to give us his pleasure as to whether we could exec this, or should we wait if he wishes to amend the phrase on line 4, full name to botanical name, lest there be any confusion. But I don't see him. And I do have Representative Knurk wishes to speak. I'll give you a few minutes.
No, just to inform you that Mike Holt, the therapeutic cannabis administrator, is still on the line if anybody has any questions for him.
I will call Mike Holt back if he wishes to address any of the questions on this particular bill.
He has his hand up and I will let him speak.
Thank you.
Uh, Thank you, Chair. Again, for the record, my name is Michael Holt. I'm the administrator of the Therapeutic Cannabis Program. I don't have any proactive testimony on this bill. I just wanted to make myself available for questions if any of the committee members had questions of the program. It is correct, the testimony so far is correct, that administrative rule prohibits the use of commercial strain names in a public setting, including on websites, social media sites, and on the product labeling. However, we do allow those commercial strain names to be available in the dispensary and through direct communication between the ATC and the patients in the form of that key that or the legend that you've heard about. So yes, this is not in law. This is in rule. This bill would certainly supersede our rule prohibition for the use of commercial strain names. The department does not have a position, again, on this bill. The rule was written based on testimony received from advocacy groups that were concerned that commercial strain names being publicized on websites and social media sites would be attractive to children. A couple of the names that we heard today were of strain names are Northern Lights and Point Break. They run the gamut, and so we added that to our rules. I will offer that we have received significant amount of pushback from patients and from the ATCs about that requirement. We've heard the arguments that we've heard today numerous times. We do a patient survey every year, and this regulation is a common source of complaint from patients saying that they cannot do their own research because they do not know the strains that are available. So
Thank you, Mr. Holt. Would the bill on line 4, when it uses the term full name, mean to you, botanical, whatever, would the use of the term full name be sufficient to strike out that statute, or would a more precise term be required?
The term that would make the law as clear as possible would be the term commercial. Commercial strain name.
Thank you.
That's the term that we use in our rules, and that's what's understood. When I think of the term botanical, I think of cannabis sativa as the scientific name.
Okay, thank you. Representative Woods, do you have a question for Mr. Holt?
Thank you, Mr. Chair, and thank you, Mr. Holt. You've answered part of my question already. Just a request, for ease of finding it, could you forward us the rule that currently is in place that provides this prohibition?
I can give it to you right now if you like. HE-C 402.09, B as in boy, 5, B as in boy.
Representative Woods, your follow-up.
No, I hope somebody got that.
Your follow-up is, would this be perhaps emailed to our committee?
Yes.
Thank you.
Yes, I
Representative
will
Gay.
email it.
Representative Gay.
My question, thank you, Mr. Chairman, and thank you, Mr. Holt. My question, Honorable Holt, no. My question is there any reason you can't put both names? Could this specify both names, because commercial names can change? So it certainly makes sense to put the commercial name, but how about adding the the technical plant name too, just to be complete?
With this, there would be no prohibition against what you're suggesting if this bill were to pass. We do require or allow the ATCs, we require them to categorize these strains into the dominant forms of indica, sativa, and hybrid when they are hybrids. So that information is generally available and it is not restricted by administrative rule.
Thank you. Representative Nelson.
Yes, I'm questioning on line number 7, where the term may list, is that an issue? The Alternative Treatment Center may list.
For me, no, it is not an issue. It would put the question of whether or not the ATC wants to use the commercial strain name or not. The language may would allow them to do it. My assumption is that all of the ATCs will choose to reintroduce the commercial strain names to their labels, their websites, and their social media sites.
With no further questions for Mr. Holt, the chair recognizes Representative Roger Dantonville, who is a co-sponsor of the bill. Representative. You're muted, sir.
He's having to be promoted to a panelist because he's using an older form.
Can you hear me now?
We can. Thank you, sir.
Thank you, Mr. Chairman, and thank you, fellow committee members. I am that representative that Mr. Josephson alluded to. I am a registered cannabis user, medical cannabis user. A little background. I have cancer. I am in remission, but I have residual effects from my cancer and my treatments. I have spoken with many cancer survivors who have found respite with the use of therapeutic cannabis, and therefore I asked my medical provider if they would, if I would qualify, and they were more than happy to sign off on me because they know what I've been through. I'm not here to discuss the merits of medical cannabis other than the fact that I find great relief in it. I am here to back up the fact that there is confusion about the labeling of the cannabis that I use. There is a myriad of ways that cannabis can be distributed, whether it be in edibles or ointments or flour or a myriad of other ways. And what I have found is that the most descriptive labeling I've found is on edibles. It lets me know if it's an indica or sativa. The problems, my residual health problems are chronic pain and difficulty sleeping at night, where an indica would be highly indicated at the time to use that for early evening and going to bed. I'm trying to work my body into getting back into shape after all the treatments I've gone through. So I develop hip and leg issues where a sativa would be more acceptable or beneficial at that time, where I could go out and walk or swim. However, I have found the same issues that Helena went through and other folks have gone through, where you really can't track the strain to see which one's going to be beneficial at that certain time. And I think I was a co-sponsor of the bill because I have walked out of there confused. And I know information online kind of directs you indica, sativa, hybrid. without really getting into the specifics. And being that it's curbside now, it's not always conducive to calling in to ATC or to going online to try to break down the specific strains. And knowing that I could read that online would save me time getting the right medication for what my health issues are at the time. So I am in total support, and I feel that as Mr. Josephson has said, that the word shall should be in there to let people, because I am an elder statesman, if I'm having issues with it, I'm sure that the people who I see in the parking lot who are set up to get it are probably in the ballpark of my age as well. I know they must be going through it as well.
Thank you very
So,
much.
You're very welcome.
Thank you for your testimony. And I'm going to ask two things. Number one, Christina, I see no one else ready to testify. Is that correct?
That is correct.
Then in that case, I close the hearing on House Bill 240 and Representative. Since Representative Conley, I do not see is still in this meeting, I'm going to ask you to do something, Representative. Would you? I don't see him either anymore. Oh, well, what I'm going to ask Representative Conley, then I'm going to send him an email, is I'm going to not exec this bill at this time, because I want to give the sponsors the choice of, do you want us to exec it as it exists, or bring an amendment to change line 4 to say commercial? And if they wish to do that, they can make sure an amendment is gotten. We can do it accordingly. Representative Weber. Representative, please unmute.
Sorry. Because the bill is now in our possession, I think it might be helpful if one of us got that amendment. And I personally would not vote for the bill unless it says commercial, because we have been told by Mr. Holtz that that's the proper term. So I will volunteer to get an amendment that says commercial and get it to the committee if the committee decides to, at some point, consider that. But I will take it on myself to do that.
I appreciate that. That saves me an email to the sponsor. Representative Knurk, you may unmute and speak.
Yes, I think what Mr. Holt said was the commercial strain name. So the wording would be specifying the commercial strain name, not just commercial name. I think commercial
I will
name would
defer
work.
to Representative Knurk and let Representative Knurk obtain the appropriate.
Thank you.
I did into trouble.
Yeah.
Well,
that's
then in
what
that
you.
case, folks, should we do the shall or the may for the first line, line 3?
They wanted the shall, so let's let them have
No, the shall answer had to do with on line 7. Sorry, my apologies. I'm wrong. Yes, you're right. Yes, shall. Yeah. Thank you. Sorry.
Okay, now the chair declares us to be quite hungry, and we will come back at 1:20. Have a good lunch, everybody. And if Christina, you could put out a sign saying this committee is out to lunch, I'm sure everybody would laugh.
Like just now.
Mr. Chairman? Mr. Chairman? Mr. Chairman, can you hear me?
I can hear you, Madam Chair Emerita.
It's okay. We can dispense with all of that. I just wanted to let you know that I got a message that I have a meeting about one of my CASA kiddos that's been rescheduled till 3:30, so I will be stepping away at that point.
Well, the bill in question could go on for days.
Well, I just wanted to let you know,
Thank you.
this
Thank you.
business of having the power over here is very exciting. And actually, I think I've begun to get the hang of it, so that if Ms. Dyer needs to step away, if nothing different from what I've seen so far comes up, I've got the hang of it. So
Yeah.
it also does let me mute people when they need muting. It doesn't let me unmute them, unfortunately, but I can only request them to unmute.
I had asked Christina if we were going to go forward with that Representative Edwards bill, and the 100 plus people who had signed up to testify in person or verbally still wanted to, and I gave them a minute. Could she mute them at 1 minute? And she said she could. As it turned out, the way the thing proceeded, most of them dropped off. I can see them, maybe you can too, on the participants list.
I can now on the participants list, yes. And that when I roll my cursor over them, I get a possibility that I'm allowed to talk. I can promote them to panelist. And as she did with the various Josephsons, she can you can also rename them so that people know who's speaking.
Good.
Which is good to find out, because CSG renamed me on a panel they were running, and it took me about a week to figure out how to put myself back to the name I preferred to use. But
Well, we're learning. I'm finding doing this from home is significantly easier.
I was sure you would find that doing it from home is significantly easier, because you've got a level playing field and you can see everybody, and the committee size is such that you can see all of the participants on one screen.
Yeah. And I can also see who among the attendees wishes to speak and things like that. So I may wind up, if I come in person next time, to bring my laptop with me and work off that.
The only issue you will find if you do that in the committee room, if other people are doing the same thing, you will have interference issues. Because I know when I was trying to get Representative McKay installed on Zoom, the issue was when I had my iPad close to his computer, it all.
You can get echoes and feedback as well.
It was very unpleasant.
Yeah.
Well, the solution for that is use your headset. Pair your headset. Or
If
plug your
either Representative McKay or I had a headset, we would have, but of course.
No, I mean for Mark, if he brings it in.
Does.
Yeah.
And well done, Lucy, regarding Jim. He's on his own. You're not in the same building with him. He did it. Thank you for teaching him.
I haven't, well, it wasn't a matter of teaching him. It was a matter of realizing that he uses a proprietary, when you email him, it's at mygate.com. That is a proprietary software and hardware that is designed to be for elders who don't want to get into the sorts of things where we push the wrong button and something happens with our computer and we never get out of whatever happened. This one, you can't do that. And he kept saying, well, Zoom is installed. So when I went and looked at it, the screen is all purple and white and it's very large buttons on the screen. And there's a lovely trackball thingy. And yes, up in the corner, there is something that says Zoom. So I clicked on Zoom and it said 100%, 125%, 150%. And it's the Zoom that allows you to make the already large print even larger. And to install Zoom, the program, you have to call the nice lady in the central time zone because they do not permit third-party installations on their programs at all, but they had to make an exception for Zoom because of COVID, because everybody wanted to talk to their grandchildren. So the nice lady in the central time zone took an hour and a half.
Wow.
To actually install Zoom on his computer. And none of us can find Zoom, and we will never see the little Zoom blue thingy. But if he has an email and it says join, click here to join, he clicks and he joins, or he clicks and he writes in the password and joins. So you can't pull up the program as we would on a PC or a Mac, but the emails take him directly to where we are. So it all works.
You know, it's amazing what we got accomplished over lunch. Fran went out and had a makeover. If you look on the screen.
I notice it.
Yeah.
Quite
I love those glasses.
I just came back.
Oh.
It's my understanding that everybody in the central time zone is nice.
This lady was incredibly kind, incredibly helpful. She was unfortunately working on a computer that was also quite slow. So we had a great deal of time to chat, but it all worked out well in the end, and we're good. It's particularly helpful when Committee Services sends out the link again 1 hour before the program, because otherwise for Jim, the emails get lost in the maw of emails. And I always write down who the email comes from so I can use the search function, but I'm not sure the search function, none of the functions on Jim's computer work the same way they do on our computers.
Right.
So nobody can talk him through things without.
I'm looking at Beth with her coffee or tea, and I'm thinking, hey, we're like we're in a coffee clutch here. Ta-da!
Yeah, with my moose. See my moose?
Oh, nice.
It's funny about technology and the speed of it improving. My wife is 14 and a half years younger than me. And the other night we were watching TV and there was a problem. And I heard myself say, maybe we have a tube going.
That frightens me because you're not much, we're in the same bracket there.
Yeah. I think Mark has a tube going.
Well, she looked at me and made something akin to what Jerry just said.
Yes. My husband and I, we married young, and when he was in graduate school and I was undergrad, we had an ancient old TV, and indeed a tube would go. He made a chart. We would take all the tubes out, go down to the hardware store, test them all, Yeah. So much fun.
You could actually fix your own
Speaking
device
of tubes,
yeah.
I have this cute little radio behind me here. It's all tubes.
Oh.
Is it represented?
I'll just remind everybody we're still on the live stream just in case anybody.
We know.
Yeah, don't say anything too bad.
Don't get wrong.
I will still say Representative Kelsey, wipe that smirk off your face.
I think it's good for the public to see us being nice to each other.
I think Nikki
You want to encourage
be my parents.
The public knows this is the best committee in the House.
Yeah.
And Jan Schmidt commented about it too.
Yeah.
Isn't that nice? So many people come. Last year, somebody said, look, you're all there, 21 of you. Whoever it was said, oftentimes they go before committees, there's 5-6 people.
Yeah.
They hate each other.
I knew it was going to be good when I got a welcome card from
people
you.
who wouldn't show
Oh,
up.
did you like that?
I did. Thank you so much.
You're so welcome.
That was awesome.
That is cool.
Can anybody quickly point me to the way the public can get on this?
It's in the calendar.
Public are listed as attendees. and they can hear us. They can't speak to us.
What is the link to it? It's in the
It's
calendar.
in the calendar.
It's in the
It's in the
calendar.
calendar, and they would have to follow the link in the calendar.
Very
And
good.
what I've done is just I copy it and then I paste it into an email to send to them if they want it. But it sometimes copies totally weird, especially if it's costs a page break. It'll copy strange, and it will copy without the line breaks. So you have to go back and put them back in because it goes 1, 2, and 3. So number 3 maybe after a passcode, so it looks wrong. So you have to go back and reformat it. At least I do. I'm a Mac user. It might work for you.
Oh,
If you put in the bill number on the search thing, it will give you a brief description. In the description, it will have the Zoom link.
oh.
Right. The question is how you get
Right.
that to somebody else so they can do it.
When you cut and paste, it reformats into a less
Ah.
helpful form.
All right.
Right.
To
So,
answer, to answer a private communication from Representative Marsh to me, I do not represent the 12th Essex County of Massachusetts District. However, I look out my window and I can see it.
Yeah.
Well, in Walpole, I could practically spit into Vermont. So
Well, it was interesting this morning as I watched the plowing Representative Knirk's street.
Oh, you can see that.
And it behind you is a glass framed something, and it
Yes.
reflects out your window.
Yeah,
So I was watching what looks like a front end loader
it
going
is.
back and forth down your street.
Yeah, I see where you can see that. Oh boy, I'd be careful. Yeah, well, I had to go out early this morning and shovel it away from the garage so we can pull it out, and then also scrape off the heavy snow off the solar panels so it won't slough after he gets done and leaving me another big
Uh-huh.
pile. Yeah.
Jeffrey, is that a portrait of you behind you?
Yes.
Oh,
Move your head.
Move your head, yeah.
No,
Yeah.
it's very special.
I'd love to get a good look at it sometime.
Sometime I had a dear friend and colleague at UNH who was a painter, and he wanted a model, and he asked if I would model, and he painted it. And when he showed it at an art show, and I bought it. I couldn't not buy it.
It wasn't Professor Hatch, was it?
No, it was Roger Beatty. And there's a long story. Roger and I grew up in the same neighborhood in Boston. We were contemporaries. We went to the same schools. We were both, and I am only trusting that Representative Weber is listening closely. We were both graduates of Tufts University, and known as Jumbos, and capable of singing the various Tufts songs. Come on,
Never
Representative
learned it,
Weber.
sorry.
Yeah.
You'll have to ask
This
Jim.
is fun, but we should get to work. It's 1:19
Yes.
and the public is waiting for us.
And
Excellent.
just a final word about Tufts. Williams beat you for 30 years in a row until recently. And Tufts has been beating Williams in football. And there's something wrong about that.
You aren't going to believe this, Representative, but I have my freshman numerals in football from Tufts.
Ooh.
Okay, let's go.
I open the hearing on House Bill 185, removing the work requirement of the New Hampshire Granite Advantage Healthcare Program. The chair recognizes the primary sponsor, Representative Shapiro. Would you present your bill, please?
Thank you, Mr. Chairman, and hello to all my colleagues. I am Representative Joe Shapiro, Cheshire 16, Keene. I come before you today to introduce House Bill 185 FN, a bill that will repeal the work/community engagement requirement for the Granite Advantage Healthcare Plan, more frequently known as expanded Medicaid. While the work requirement is yet to be implemented, it should be noted that it remains in statute and efforts to make it a reality continue to be pursued in court. The work requirement first came to be when a compromise was reached in 2017. Expanded Medicaid would be renewed for an additional 5 years, and a program to ready recipients for work and discourage long-term reliance on state benefits would be embedded in the law. Requiring 25 hours of work and/or community engagement made it the most extensive requirement in the country. I fully understand that this was a good faith bargain made by Democrats and Republicans, allowing both sides to fulfill their priorities. In the intervening years, however, the landscape has changed dramatically and the work requirement is no longer viable. Therefore, it is time, in my opinion, to repeal this segment of the law. Since being signed into law, the following have occurred. Arkansas put a similar program with less required hours into effect in 2018, causing some 18,000 beneficiaries to lose their Medicaid benefits. In 2019, New Hampshire attempted to roll out its program, but it had to call a halt to its efforts when it was unable to enroll 20,000 of the 50,000 recipients subject to the requirement. According to the U.S. Government and Accountability Office, that effort at implementation failed in spite of expenditures of $4.4 million, 187,000 of those dollars in state funds and the rest in federal monies. A federal court ruled that the Arkansas program was not lawful. In July 2019, the U.S. District Court for the District of Columbia ruled that the New Hampshire program was invalid, saying that providing medical care to the needy is Medicaid's core objective, and that the federal waiver failed to adequately consider the work requirement's effects on Medicaid coverage. In other words, Medicaid is designed to provide health care, not job readiness or character building. In response to an appeal, the DC Circuit Court of Appeals ruled once again in February 2020 that the U.S. Health and Human Services lacked authority to approve the Arkansas program. Since the Arkansas and New Hampshire programs are essentially the same, New Hampshire joined with Arkansas and the Trump administration to appeal to the U.S. Supreme Court. 2 months ago, the Supreme Court agreed to hear the case, and presumably a hearing will occur this spring. If an effective work requirement was ever practical, it is clear that COVID-19 has now created many new obstacles. Having people lose their insurance during a pandemic is unwise and ethically questionable, and requiring more people to engage in work and/or volunteering will serve to heighten the current public health crisis. It is time, in my opinion, to repeal the Granite Advantage Healthcare Program work requirement. This was a program conceived in good faith by Democrats and Republicans with different philosophical points of view, which has proved to be unworkable practically, legally, and now from a public health standpoint as well. At this point, repealing this segment of RSA 126AA will merely align New Hampshire's statute with the federal reality. Thank you, and I am willing to take questions.
Hearing no questions, the chair is looking for the list of who is up to testify. And I don't really have that from House Committee Services.
I
I'm
can
going.
help out with that.
Thank you. Of course you can.
We do have Henry Lipman from DHHS on the list.
Mr. Lipman, please come forward and present your testimony.
Good afternoon, Mr. Chairman and members of the committee. Here on an informational basis today in terms of adding to what Representative Shapiro outlined for you last night I came across that the Supreme Court is expecting oral arguments in this case on March 29th. And it is in litigation, and I'm basically here to answer any questions that the committee might have on the requirement or kind of where we stand at this juncture. I'll add one other thing just in terms of the the pandemic, that in the public health emergency period, states who are accepting an enhanced FMAP percentage would not have the ability to drop people from coverage. That's just an expansion in terms of what was outlined about the concern of the public health emergency, that if we were being in that period, all 50 states and territories, to my understanding, have accepted the maintenance of effort requirements, and we're not permitted during that period to drop people from coverage.
Representative Marsh has a question.
Hello, everyone. Can you hear me?
Yes.
Yeah, I don't like the cell phone thing. It's harder to know whether you're connected or not. Thank you, Mr. Chairman, for taking my question, and thank you, Henry, for appearing before us. My question regards the pending litigation. Would that litigation become moot, and therefore we would save the the state of New Hampshire money were this bill to be signed into law?
Thank you for your question. I think that if the Supreme Court were to find that the Secretary of Health and Human Services federally had the, if you will, the authority to implement this, we would have to go through a process of applying for another waiver, because the current one wouldn't automatically go back into effect, to my understanding.
Thank you very much.
Any other questions? Seeing none, the chair recognizes Dawn McKinney from New Hampshire Legal Assistance.
Good afternoon. This is Dawn McKinney. I'm the policy director at New Hampshire Legal Assistance. Can you hear me?
We can.
Okay, thank you. I feel like I will be brief. I thought Representative Shapiro's overview was excellent. And I just wanted to kind of share our thinking with you on this. We support HB 185 to remove the work requirement from Granite Advantage. New Hampshire Legal Assistance has consistently opposed the Medicaid work requirement because it is contrary to federal law. Medicaid is a healthcare program, not a work program. People need healthcare to stay healthy so they can work, not the other way around. In fact, 2/3 of those on Granite Advantage are in working households. That is why our organization fought this in federal court. And if the work requirement wasn't halted in August of 2019, nearly 17,000 New Hampshire residents would have lost health coverage. This is despite the significant efforts on the part of the Department of Health and Human Services to inform people, and the previously mentioned $4 million spent by the state to implement the program. While this was prior to COVID, the pandemic reminds us of how important healthcare is not just to individuals and families, but to the public health of our communities. Likewise, the resulting economic fallout is a reminder of how uncertain work is for those who rely on Medicaid as a safety net. We urge the New Hampshire legislature to pass this bill, removing the work requirement to provide Granite Staters peace of mind. I'm happy to answer any questions.
Seeing no questions, thank you, Ms. McKinney, for your testimony.
Thank you.
I have no other names. Christina, are there names that you have that have asked to speak?
I have no one else on the list.
Any further discussion from within the committee? I really expected to be here till 5 o'clock this afternoon.
this is
Representative
fine.
Weber told me that there would be days like this, and they're usually Monday through Sunday. So with that, I close the hearing on House Bill 185 FN. You've been a good audience, and you can now go out and play.
What, Mr. Chair,
Yeah.
what about executing that bill we just heard? There's nothing that has to be worked on.
Well, there are some of the people in the room here are telling me that they would like to wait a little bit to see how the arguments go before the Supreme Court.
We
And,
have to decide long before that, don't we? Didn't you say March 29?
I think that's crossover.
We have to act before that, though.
We do,
Yeah.
and we will.
I'd just like to chime in and say, I think we've had a very intense couple of days, and perhaps letting the dust settle on everything at this point might be helpful. And I just want to thank the chairman again, because this is not easy. And much as I am sorry that the timing didn't work out as you had expected, I'm glad it's not just me who has days like this, because I certainly had my share of them where people were either sitting and waiting for the next hearing forever, or I was apologizing to people for having overscheduled. So
My turn. Representative Marsh.
Yes, thank you. And in response to Representative Knirk's question, I personally am happy that we aren't voting at this time, because I don't want to address the issue as to whether I'm going to be allowed to vote over a cell phone when you can't see the whites of my eyes or not. So therefore, I would be very happy to wait until my internet comes back up.
We can see the whites of your receiver.
Yes, I was schooled by our wonderful House clerk that I needed to see your face on any vote. So that's why I keep looking at my screen when I'm doing the votes, because I'm looking to find you which little box you're in.
And by the way, I want to just check, Representative Marsh, did you actually call in on the dial-in number, or did you use your phone and use the Zoom app?
I called in on the dial-in number, and in fact, I had to text Christine how to do that, because I didn't think that this would ever happen, and to lose my landline and my internet at the same time in the middle of a hearing when I didn't see the bills
The
was
reason I
stressful.
bring it up is I've done a Zoom on my phone, and if actually you have your Zoom app on the phone, you can actually go to the meeting through Zoom.
Yes.
And when you go to the meeting through Zoom, you are visualized.
Only if you have the meeting link, though.
Yes.
Yeah. But
Well, I would have that in my emails, but it never occurred to me to install it on my phone, because I hate doing things on my phone because the screen isn't big enough and I can't see it. And I like to do things on my little tablet. So I will consider that.
Yeah, it's a good idea for everybody to have a backup during this time, conceivably, because this may happen again with power outages or this or that. And so, yeah, you can download the app. It's not what you want, but I've done it now twice, and it worked out okay.
Representative Marsh, you are a retired eye surgeon. Do something about your eyes so you can see it.
Yeah, but I don't trust anybody else.
And yet you were willing to have me have my procedure on a committee table last year.
You likely would have done very well.
Well, yeah, and we were all the psychologists and counselors around there to do the after action thing that the trauma is causing. Yeah, thanks.
Yeah, they were all fighting over who would get to hold your hand.
Well, that's Representative Woods, of course.
Are we still in a public session? Or are they?
That's what I was going to say. We're still live.
We're still public.
Well, that's why
So
they
we gotta
tune into
watch it.
this channel. Representative Cannon.
That's what I was going to say. I'm all set now. We're live.
We're just fun people.
Yeah, it could be Saturday Night Live. We can post it there.
It really could be.
This is the comedy relief. You know, we've been talking about cannabis all day.
Well, you know, I would point out the masterful restraint from this committee that when we looked at the cannabis bill in some detail, nobody used the phrase, wait for it, we're going down into the weeds.
Well, that's right. I was sent a text that the quote of the day is me saying, quote, minimizing the side effect of euphoria, end quote. And I do have to agree that usually euphoria is not a side effect, but here it actually is because it's not the therapeutic effect.
For your amusement, you probably know that it's my habit when we have a bill that I go out and I do my own research. So on the telemedicine bill, I went to every therapist that I knew who was not on the committee to ask them what they felt about doing this over telemedicine. And what I learned was that if you are a patient,
is this allowable?
Bad territory here, folks.
No, it's okay. And if you lay all the therapists in the state end to end, you will still not reach a conclusion unless the patient wants to find a conclusion.
Okay.
That sounds like a California joke.
I'll meet you halfway, maybe a Kansas City joke.
Easy.
Oh, is that Nikki? Is that where you're from?
That is.
Oh.
Go Mahomes. Go Kansas City.
Central time zone again. We talked about the central time zone earlier.
Yep. Everybody in the central time zone is sweet.
Yep.
Well, we're at least friendly.
Yep.
Yes.
And see, I could move from Texas to live free or die because that really fits the Texas attitude.
I
Remember-
thought it was live free or kill.
No, it's remember the Alamo.
No.
Remember the Alamo.
Let's not go there.
Nikki, that is a cute dog.
Oh, thank you. I have two of them. Where are they? I don't know. Do they count as votes?
It was right behind you.
Not in this state.
Are they still in here? Oh yeah.
Oh, look at Doug Weber. Oh, look at Doug Weber.
That's my personal assistant.
Yeah. You know, it was fun yesterday. You probably overheard when Heidi Kroll was testifying, her son kept making some noise in the background. And when I had a Zoom meeting with her just a couple of weeks ago, we were trying to get some work done. And he was hopping on her lap and stuff like that. And again, it's so much fun to see people's dogs, see their kids, that kind of stuff. But I felt bad for her trying to testify on a bill, and her kid is making noise in the background.
Mr. Chairman, I just, are we done? My daughter just called and she has a snowblower problem, which she would like some help with.
I think we're done. I'm just taking things up with my skeleton crew, and I think we're out of here. Thank you. Good night.
Bye, Carrie.
Bye, everyone.